Very good morning, everyone. We are heading towards the session that is mixed bag. We are towards the ending of our the Mahakritikon conference. It started from the 2nd of November, and today is the last day of it. And it was very generous of you, and thank you for participating in this conference. So I would like to call upon Dr. Satish Devpujari sir, Senior Pediatrician Intensivist from Nagpur, as a chairperson. Dr. Mahendra Chauhan sir, Trauma and Emergency HOD AIMS Nagpur. Dr. Manoj Chauhan sir, Senior Physician from Bhandara. Dr. Ranjit Mohite sir, Physician Intensivist from Kolhapur. On behalf of Mahakritikon Nagpur, we all welcome you, sir.
Yes. Good morning, sir.
Dr. Manoj Chauhan sir. Now I'd like to call upon Dr. Reshu Gupta Kanikar madam. She is DA IDCCN FSNCC Senior Consultant in Department of Critical Care Medicine. She is from Health City Hospital, Guwahati. Ma'am's topic is challenges in management of Clostridium difficile.
Very good morning to all of you. First of all, I would like to thank the organizing team for inviting me to this beautiful city. This is my first time in Nagpur. So I thank you again. So the topic of given to me was C. diff, Clostridium difficile, the challenges in the management. And I would be touching on these issues, the epidemiology burden, the pathogenesis little bit, risk factors, clinical features, and the management challenges and the infection control measures. So we know that C. diff is an anaerobic spore forming gram-positive bacillus. It's leading cause of healthcare-associated infectious diseases, diarrhea, especially in hospitalized or antibiotically treated patients. And we are talking about this today because of the rising incidence and the recurrence rates. What it has become a major public health concern. If we go to the epidemiology, the main concern now is the occurrence and as well as the recurrence of this infection. And the recurrence rate as reported in 2020 in the US was they have seen in 101 out of 1 lakh population, and this rate is increasing disproportionately. In India as well, this has a wide range of incidence. Okay, it's okay, fine. Okay, so it's rising. It's from a range of 1.2 to 29%. The range is wide because the incidence, the reporting, the registry is limited. But now with the increasing rise of incidence, it is now coming up in a big way. It is the primary driver of the overall disease burden is the recurrence of the C. diff infection, which has increased, as I've been mentioning, disproportionately compared to the initial infections. And the factors which contribute to this recurrence are the use of antibiotics, we damage the gut microbiome, the inadequate immune response, the age and the presence of the comorbidities, the prevalence of newer strains, which are hypervirulent strains, the persistence of these spores which remains in the environment throughout, and one more important but least concern which we often tend to forget is the gastric acid separation. So these are the factors which contribute to this recurrent CDI infections. again and again. So to summarize the key risk factors, the rampant use of antibiotics, hospitalized patients with extended periods, patients with various drugs like I've mentioned, gastric acid suppression, and the other factors which include the risk factors are the immunosuppressions, the chemotherapy if the patient is on, and comorbidities like chronic kidney diseases. So just very shortly about the pathogenesis. The antibiotics, what the patient is on, it disrupts the normal blood flora. Then there are toxins which are liberated from this C. diff overgrowth, like the toxin A and toxin B, which is the enterotoxin and cytotoxin respectively. It causes inflammation and the mucosal injury. And these spores, they persist in the environment for long and they resist the standard disinfectants or standard precautions, the infection prevention measures what we take in regularly in ICU. And the host immune response, it plays a key role in the disease severity and the recurrence. So if we see, we have started the patient on antibiotics, the normal flora decreases, C. diff colonized, the toxins are produced, it leads to epithelial injury and inflammation leading to diarrhea and ultimately the pseudomembranous colitis. Also, because of the presence of this spore, these spores are ingested by the patients, which in the GI tract, because of the presence of the bile salts, these spores, they germinate, causes the toxins liberated, which leads to inflammation and the damage. And again, these patients shed these spores and this vicious cycles goes on. So clinically, they have a spectrum. They may present with asymptomatic colonizations leading to just mild diarrhea, leading to pseudomembranous colitis, toxic megacolon leading to sepsis, and severe then leading to mortality. So clinically, they present typically as mild forms like just watery diarrhea, fever, there might be abdominal pain in a patient who's hospitalized in the ICU for long. But severe infections, the indicators are a rise in WBC count if no other causes of other hospital-acquired infections are seen, a raise in the creatinine and hypertension, ileus and megacolon. So with these clinical features, if we have a patient who's having diarrhea, we need to suspect C. diff infection. For diagnosis, it's very simple. It's just a stepwise approach. You first initially screen for glutamate dehydrogenase antigen. If that is positive, you detect the toxins, toxin A and toxin B. If the toxins are positive, this is a positive result for C. diff infection. But if it is negative, even with the glutamate dehydrogenase positivity, it is negative if the toxins are not present. So in management, we need to manage first by the general measures. You stop the antibiotics, stop the culprit, what the patient is on, maintain the hydration, resuscitate the patient, maintain the electrolyte balance and avoid any anti-motility agents which the patient may be on. Then you assess the severity. So when we assess the severity, we can categorize the patient into three categories, that is the non-severe, the severe and fulminant. The non-severe means patient is having diarrhea but the counts and the creatinine, the organ dysfunction is yet not present. So there we may start with vancomycin after we have confirmed the C. diff infection by by identifying the toxins. We can start with vancomycin low dose 125 milligram per orally QID doses, continue for 10 days, or fidamoxin is the second line of drug. In severe, again, it remains the same. Severe category is if the WBC counts are high or we have some organ dysfunction, especially the kidney, if the creatinines are high. In fulminant, if the patient has some signs of hypertension, shock, ileus or toxic megacolon, we have to increase the dose of vancomycin to 500 QID plus add on another agent, that is the metronidazole. And if ileus persists and it is present, role of rectal vancomycin comes here. In recurrent infection, if it is the first recurrence, then fidaxomicin is the drug of choice and vancomycin in pulse therapy or taper. And if it is multiple recurrence, then we have the fetal microbiota transplantation, which is now the topic of discussion, especially in C. diff infection in prevalence. So the treatment options, we are left with very few drugs, that is vancomycin, metronidazole and fidaxomicin, which is the newer molecule in the market. So what are the management challenges? We have huge antibiotic resistance, especially in this C. diff infection. Now when you see, even this has, as I've said, the incidence is rising, it is becoming more and more common. When we put the patient on such patients, when we just put the patients on vancomycin or metronidazole, still the patient have a recurrent C. diff infection very soon. So the susceptibility to metronidazole and vancomycin is reducing, and the presence of this hypervirulent strains, which I have been saying, these are coming up. So these delays the management, this prevents the patient being treated, and recurrent infection, this is occurring in almost 20 to 30% after the initial treatment, and we know about the risk factors, and despite it is difficult to manage these patients even if the patient is put on optimal therapy. So the new evolving therapies which are now coming up is one, as I've been mentioning, fidaxomicin. This is a narrow spectrum macrolytic antibiotic. It reduces the recurrence. Another monoclonal antibody by the name of meslituzumab, this has been coming again, especially in for the toxin B, which is coming. Fecal microbiota transplantation, specially used in recurrent infections, is very effective. They have said around the success rate is more than 85%, which is pretty good. And under investigation, there are few vaccines and probiotics which are coming up in the market, which are yet to be come. So this summarizes the whole immunotherapy of a C. diff infection patients, not only in the primary but in the recurrent phase as well. Important here is, last but not the least, the infection control measures which we need to highlight on. So it's not only the alcohol rubs what we are promoting always, because the spores are resistant to those and they survive. So we need that the surface cleaning, the hands should be washed by soap and water. So these are the different ways we have to stress on. So prevention strategies, hand washing with soap and water, just not the alcohol based sanitizers are enough. We need to isolate that patient. We need to give, if possible, 1:1 nurses, contact precautions and environmental cleaning with the sporicidal agents, not the routine infection measures what we are doing. And very important is the antimicrobial stewardship program. Those are very important. We have to practice de-escalation of the antibiotics as soon as possible to prevent the recurrence, to prevent the infection being given, that C. diff infection to be given to the patient. To summarize, the key challenges are the increasing incidence and the recurrence, the limited effective antibiotic use. These we need to practice, the environmental persistence of this and the transmission control. We need to balance the antimicrobial therapy with the antimicrobial stewardship programs, and we need newer therapies. We are only managing with 1 or 2 drugs in our armamentarium, so we need some new novel therapies, as we have seen the vaccines which are yet to come, which are being in the process of coming to the market. So to conclude, C. diff infection, it remains a complex clinical and infection control challenge. Effective management requires early diagnosis, rational use of antibiotic, infection control measures, and integration of new therapies such as fidaxomicin and the monoclonal antibody and the fecal microbiota transplantation. And we need a multidisciplinary approach. We as intensivists alone won't be able to manage. We need a strong infection control team who are there to manage, to give support besides the healthcare personnel as well. This is one of the workshops we are being starting. This is a hybrid model. I welcome anyone who are interested. This especially is on high risk obstetric care courses. Thank you so much.
Thank you. Thank you so much for your excellent presentation. And if you have any question, we will talk. We will take at the end of the session. Thank you. And now I invite Dr. Ajit Kumar AK, leading consultant, critical care medicine, Esther Whitefield Hospital, Bangalore. and he is speaking on AI in critical care. Over to you, sir.
Can I start? It's a good day. Uh, so the topic is an artificial intelligence in critical care. So basically, I should disclose that I am a clinician. Obviously, I may not be an AA expert, and obviously, I had not used to know any kind of AA thing. But obviously, as one of the active persons of an Indian Society of Critical Care Medicine, we are planning to start an AA course for the critical care intensive. It is going to be declared, next week. So basically, I also trying to learn, how the AA is going to be in the ICU, and it has to be covered in 15 minutes time, in a very short period. Yeah. So basically, the discussion is about, the today's, error-prone ICU, and obviously we have a lot of, already there's a lot of, psychological stress is there, and obviously there is a lot of, error is also likely to happen, and ICU is having a very high stake. So what I mean to say that stake means that whatever decision you make in an ICU, it is going to be like a sort of a do or die sort of thing. Whether it is going to be extremely crucial for the patient to survive or die. So it's a very high stake. It's a very high stake environment. And what are the opportunities for an AI in critical care? And disadvantages and limitations of AI and the future directions, and finally the take-home message. So the most challenging environment, we know that we need some time-sensitive interventions. Quick decisions are needed based on clinical history, patient status, and the large voluminous data, because there is a lot of data is there. Obviously, you need to correlate the data. It is very likely that any human can miss it. And obviously, it is burdened by the factors like clinicians, cognitive fatigue of the clinicians, and obviously delays in diagnosis can happen. It is not uncommon. And this environment, this high stress, high stake, high emotion environment necessitates solution that can support, decision making while alleviating the burden of healthcare professionals. That is how the AA is thinking in terms of critical care. And obviously, there's a very recent paper that's about an exploring the dark side of the moon, actually diagnosing critically ill patients. So basically, there are a lot of, if you look at the fishbone, so-called fishbone analysis, there are lots of things are there where you can have a error can happen in the ICU. It can be an organizational part, it's patient characteristics, the language barrier, altered ventilation, a lot of clinicians in internal state, stress, sleep deprivation, data, too much the environment, all these things, all these things to errors can be there. Obviously, you are trying to do the artificial intelligence to reduce the errors in the ICU, and whatever you are delivering is in a much easier, much safe manner. That's what we are looking with artificial intelligence. So basically, artificial intelligence is a technique that attempts to replicate human intelligence, analytical behavior. That's very important, because the one difference between a simple computer and you and me, what I mean that we are able to analyze, and decision-making capacity. That's very important. And obviously, AI's ability to analyze, comprehend, and interpret considerable volumes of data. That's very important. That will be make AI from different from a simple computer or calculator, because volumes of data, volumes of lakhs of patients of data can be analyzed by the AI. That is advantage of that. AI. So basically, the world of artificial intelligence is a big area, because artificial intelligence, there are lots of subdivisions are there. Everything encompassing inside the artificial intelligence. Machine learning is there, one part where you make some models and algorithms for the machines to learn. You give the training data to the machine, and there is a process, because I am not an expert in that, but you give some models and algorithms so that the machine will identify. Supposing you give around data around 5 lakh people to a machine, so machine is going to look at the data. You process that, which are the patients which are the patients who died actually. So what are the characteristics of the volumes and all the data, whatever the white characteristics, everything, and how it can be made into some kind of conclusion. That's the machine will try to tell you. Neural works in a human attempt to mimic the brain in different levels of knowledge. And deep learning is, further thing, like, convolutional neural networks where, the image processing can be done. Image processing means you try to interpret a CT scan, because there is a multiple inputs are there, different level, different cross-checking. It starts from the periphery to central, that kind of a thing. And obviously, you have other test models are there, some kind of a, the deep learning other techniques are as well, it's also there. And generating AI, we are all familiar, because because even when you Google something, you find a generative AI. This is the process of AI, which is collecting the data with a validated AI, AI trials, the test tools. So if it's adequately validated, then you collect all the data from the validated AI thing and it is put in your finally you generate a data. That's called generative AI. So all the divisions are there. It's a very sort of a complex thing. And obviously these are some of the jargon, natural language processing. Obviously you want the machine, what you're putting there, the machine has to understand. There's a different thing. Predictive analysis, very, very important. Mortality, morbidity predicting, critical illness predicting. This is the initial thing which is going to happen in the ICU. And obviously these are some of the jargons which you can come across when you analyze the thing. Sometimes in logistic regression even we do in our calculation, but random forest, support vector machine, k nearest neighbor, neural network, multi-layer perception, distance tree, all these things come out of the jargons, with the AI is trying to analyze. Because here the difference again I'm trying to, apart from a randomized control trial, what is going to happen is that here it is a lakhs of people. It is not like, you are 500 people, 1,000 people, data is analyzed. It is going to be a huge amount of data, and obviously that is that these statistical principles may be used, and which will be very interesting in this session. And basic AI applicable critical care, one is predictive analysis. You can predict the mortality, morbidity. Studies have shown that it is much superior to the SAP score. I mean, the scoring system, Apache SAP score, even a Framingham Hearts score, etc. Basically predicting, mortality, acute coronary syndrome, ARDS, etc., etc. And obviously you can have a lot of, alerts can be there, and real-time monitoring alerts, which I am coming to that. And advanced diagnostic, it is very important. Integration with clinical decision making, augmenting clinical expertise. That can give you more ideas. If you just put it in the system, it will give you much more idea, because all the data is in one place, and obviously can increase the workflow efficiency. So coming to the prediction, early warning system, we all know that AI predicting cardiac arrest, acute kidney injury, ICU readmission is there. Studies have been showing even for 1 to 6 hours prior to the thing, AI can predict with an accuracy of around 70 to 80%, which is very, very interesting. And real-time deterioration alert is going to happen. And one very important thing of this AI is that it will give you only an alarm when you have an actionable thing is required. When there is an actionable issue has happened. Otherwise, the false alarms are paradoxically will be significantly less with AI. Only the actionable thing will be shown. That is what it is. And when it comes to this kind of sentinel events, when you detection, studies have shown that the sensitivity of this, the early warning scoring system and so far maybe 70 to 75%, whereas the A is around 85 to 90, and specificity around 65 to 72, A is 80 to 90, and response time, because A is running fast, within few minutes you can diagnose. So what I mean to say is that the sensitivity is very high because of large voluminous data. It is not only just one variable, two variable, it may be multiple variables, and specificity is very high. Response time is going to be short. That is what the attraction or the proportion of AI in critical care in any healthcare settings. And obviously there are different studies are there, because of time comes I won't go in the Korean studies, 1 to 6 hours before that you can do that. Early mortality prediction has been there, accuracy is much better. As I told you better, coming to the alarms are basically 30% less than whatever the routine, our routine ICU alarms are there. That is also very important. Only actionable events will be given to you. You won't be distracted. You will be given more time to concentrate on the work what you are expected to do. That's what the AI enthusiasts are claiming. I am also a learner. That's the thing. And coming to the diagnosis accuracy, when you have a diagnosis accuracy of 75%, AI accuracy may come to around 90%. You can see that it's around a 78% accuracy of any radiologic data. You can see that it's around 92%. So obviously AI is definitely defeated humans. We need to agree that we need to admit that AI defeated humans in interpretation of the CT scans and X-rays. There is no doubt about that. That is the reason it's going to be there. Even in my hospital, we put some of the reports when there's a delay in readout diagnosis into the AI, and we get a reasonably or more than reasonably appropriate response we are getting. So that is what I'm trying to. It's very useful in that way as well. So application way in respiratory management, obviously there can be lots of arenas are there. For example, this study was predominantly on the pressure control ventilation, and where they study the compliance and the resistance very, very closely. And any change in compliance and resistance was alert to the physician. And what the AI is looking at tomorrow, it is going to be like a feedback system, the closed loop system. Let's like adaptive support ventilation. You will be doing the appropriate correction, looking at what is happening in the compliance, what is happening in the resistance. That is what is going to happen in the future. And obviously one very important thing is that AI is definitely superior in predicting when to wean, when to start the weaning, when to extubate the patient, and these kind of things. That's also I just want to tell you. And obviously the identification of ARDS phenotypes, you give the data, there is nothing, patient has come to you, press the button, you can see that this patient is in a hyperinflammatory phenotype, the ARDS management and outcome is going to be different. We all know how the things are working. And obviously there are different, thing with the same thing which I already mentioned to you. This I just mentioned there. And there is a peak into the future because of time constraint. I'm not reading everything. There is a lot of, again, ventilatory extubation which I already mentioned to you. And obviously there are electrical impedance thoracoscopy imaging. And that could be much more clear with AA, much more interpretation, much more easier. And another very important application of AA in the early sepsis detection. That's also very, very important. And obviously various studies are there, which is showing much superiority. For example, if you look at an AA in predicting sepsis, the AA models have been around sensitivity is around 88.5%, whereas in other models are around 70 to 75%. So AA is definitely much superior. It is more specificity and sensitivity is there. That's what I want to highlight. And obviously, AA application by name is acute renal injury, acute kidney injury management. You can predict the ESRD, predict the contrast-induced nephropathy. Which patient is going to expect this? Whatever best we can do, how much we can do. Automated deep feature classification to differentiate malignancy from benign thing. Optimizing the EPO dose. These are some of the indications. I don't want to read about that. And obviously, in emergencies, it can help in triaging, looking at the patient's data. It can accurately triage the thing. Sometimes, the current criticism is that it will be a little bit more over triaging will happen. Some of the patient may be over, that's the initial thing. It is again going to be corrected in the coming future. And in other areas, clinical decision support systems, it can help you. You put it in the particular algorithm, it can help you whether it's going to be useful or not. Antimicrobial stewardship is another area where AI can definitely help you. ICU dashboards integrating AI into the clinical workflows. AA scribes. Another very practical thing is that AA will definitely help you to have the notes. You don't have to write a note. You can just, you can dictate the thing. It can be written. It can be minor correction is required. You will definitely, take a lot. You don't have to write in two places. Like, you will save a lot of time in that. And obviously, bed allocation, nursing staffing, drug inventory preparation, etc., can be definitely done. And basically, when you ask for AI, suppose I want to, because naturally I want to start an AI, what exactly is required? So naturally, number one is that at this point of time, because I have been trying to contact, some kind of AI, some group of people, who are dealing with the AI, it has not been adequately, well developed in India. It is going to come in another coming years or maybe, another 5 years to there. It's going to be fully active. And obviously, the number one is that the administration as a clinician need a conviction. It is going to be useful, number one. Number two is that subscription, once it is there, whatever the data has been done so far, there are AI tools are there. We need to subscribe. Just like you subscribe the TV, whatever the channels you subscribe, you need to subscribe the particular tool. And obviously, another very important thing is that you should have a place to store the large volume of data, because whether your hospital, this one you need to store the large area, most likely maybe in the clouds. And accurate and appropriate feeding of all data. That is very, very important. If you make an error in the data, it all depends. Garbage is in, garbage is going to be out. The data is very, very important. Whatever data you feed, based on that, AA gives you the report. The wrong data is, fed, it is just going to be difficult. And ongoing data documentation is very important thing is only in electronic records. So now onwards, if you want to go for the AI, you have to see that the data is accurately recorded and you are going to be electronic health record. You can't have a handwritten thing and just go for the AI to analyze that. AI cannot identify that. And obviously, what we require is every patient, if you are looking at the AA implementation in your hospital, patient will require a small tablet or a website or laptop, preferably a tablet, at least a tablet as the bedside. And obviously, you should have an uninterrupted net system, internet system. That's very, very important because, because that can definitely affect your thing. So basically, what the AA does is there are two types of data. One is a testing data, where you program the thing, machine learning thing, the voluminous data, lakhs of people, you analyze the data, and then based on that you predict the thing. Then you training to say the training data. That's a large of thing. Then you are testing data. This is much smaller than that. The testing data, the training data may be around 2 lakh patients, but here the training data may be around 5,000 patients. Then you see that you compare with the human thing, what is better, which program is better, which analytical AI model is better. Then you identify the thing and then you try to apply in the routine thing. And the limitation and challenges in AI. The adoption barriers are the resistance to AA in clinical practice, trust deficit. Nobody can 100% fully trust the AA. And obviously, AA is rapidly evolving. I'm telling you, even before you and me know. Human inertia, there is a tendency by Newton's, the law of motion. Every person and the object in the universe has like tendency to continue the same, the direction, without changing any direction, it will continue. And clinician insecurity. People are worried that if AA is coming, my importance will be lost naturally. And economic constraints, high initial cost may be high. Prohibitive cost of smaller institutes. If it's a smaller institute, it's going to be prohibitive. The cost is going to be prohibitive. And operational barriers may be the fragmented EHR system. The data is not good, means it's not going to be successful at all. And the fear of increasing unemployment, it is very unlikely to be increasing unemployment, but if a time is that I can discuss. And finally, maybe because of political reasons as well, because a lot of reasons could be there. We don't want AA, people can tell you. So I always think about the Newton actually, we talk about inertia, because everybody want to just continue the same. We don't want to change, that's a very common, normal human tendency. And obviously, you can have ethical as well as legal dilemmas. The consent has to be there, transparency has to be there, autonomy has to be there. Who is accountable for the AA-driven decisions? If the AA is telling this patient can be palliated, then who is going to palliate the patient? Nothing to be done. AA is telling this is not unlikely to solve. Who is going to do that? That's always an issue. Which AA system is better? There are a lot of AA companies may be there. At some stage, it's going to be there. Which is better? Which is adopting your hospital? Then the system may come that you can only buy something which is a cheaper version. You cannot buy a costlier version. So the type of treatment given will be different. All these issues are there. And privacy is likely to be violated. That's also any major thing. So this is one thing which I just recently come across. This is my letter to the IGSCC editor. So basically just reviewing a paper because I asked the AI how, because the paper, the data was given in milligrams. I'm used to lactate value in millimoles. So I just asked the AI how to convert the in milligrams to millimoles. AI told me very confidently that you divided by 18. But in fact, then when I divide by 18, what happens is that the patient's lactate is coming less than 2. What I mean is that this paper does not merit anything. I outrightly rejected the paper. Rajma telling that this does not come into the definition of septic shock because septic shock usually be more than 2 millimoles. But then after some time I just thought that the other may not be that bad. I started thinking, then I thought there could be some error. I came to know that instead of dividing by 18, it has to divide by 9. So this is an error by this one. I wrote a letter. Now the Google has corrected this thing recently. And the privacy is extremely important. It's not very small joke actually. It depends on that. Whenever the world leaders Putin or Trump meets, because they will go to the toilet only in a specific toilet. The urine will be collected only in one place. Even the sweat will not be, the shirt will not be changed on any account because you can detect a lot of diseases and disorders through that. If somebody comes to know that one of the leaders is going to pass away, he's having a terminal malignancy, in another, whatever is any data, it is going to have a lot of implication on that. So the privacy is a very important thing. Another thing is that sometimes when the AI brings you whatever is there, sometimes AI may not be able to tell you how it calculated actually. This may be inherent to the machine. This is called black box problem. You won't be able to explain. There are some new methods, the SHAP method and all, but usually what happens is like SHAP method, line method, usually how it is calculated with the huge data, AI will not be able to explain to you. So even though AI said this is the way you may not trust it. So that's called black box problem. And proposed strategy is basically interdisciplinary training system, real-time customized AI model, federated learning. That means you are trying to give the test data to the training data to the system without exchanging your real data. That's very important. Advanced explanatory tools are there. And obviously human machine cooperation is there. AI liberates professionals from unnecessary jobs and distractions. That's what the AI enthusiasts are claiming. It is not going to lose your job. It will help you to concentrate. Only unwanted things will be stopped. Only on the work where you are supposed to be, you cannot be replaced. That's the only thing you need to do. These are some of the AI validated tools. EICU, sepsis watch, DeepMind streams. Basically, DeepMind stream may stop because there is some concern regarding the privacy issues. And the future direction will be digital twins. What I mean to say that every patient, every human on the earth will be having a duplicate stored in the system. So it is just like a virtual fellow. So how I am aging, whatever changes are there, everything will be updated on the system. It's an exact replica of the human in a virtual thing. So if I have a disease, I'm talking to somebody in USA, he's looking at my virtual, he's going to tell me what it is. So predictive analysis, federated learning, which I already mentioned to you. I'm sorry that's taking a little bit of time. Take home message is very simple. AI critical medicine is rapidly evolving as they can provide crucial dynamic inputs of predictions based on retrospective as well as currently active data. AI is a supporting assist tool and not a replacement for the caregivers. Data quality determines AI quality. Radical changes in documentation is a must to ensure quality of AI inputs. Human judgment remains central. Ethical and legal dilemmas need to be solved in parallel with ongoing growth. This is a very interesting paper which has, ICU designed in 2050. It is showing that all the data will be stored in the system of all the patients and depends on the AI, robots and the humans. We are going to treat the patient in the future. Thank you very much for your patient listening.
Thank you, Ajit Kumar sir. Now moving forward for the next topic, the most important thing for all the intensivists is ABG. So the topic is interactive ABG cases in critical care, for which I would like to call upon Dr. Suresh Ramasubban sir and Dr. Venkat Raman Kola sir. First I'll introduce Dr. Suresh sir. He is senior pulmonologist and intensivist from Apollo Multispecialty Hospital, Kolkata.
And Dr. Venkat Raman Kola is Clinical Director, Critical Care Medicine, Jasoda Hospital, Hyderabad. Over to you, sir.
Thank you. We will do it in pairs. So what we had said is always difficult for two people to be on the same page. So what we'll do is I'll do the first as we go kind of a thing, and then solve as we go, and the quiz will be done by Venkat. So that we have 4 cases, I think, 4 cases if I at the end of it. But what we'll do initially is just solve the ABG as we go. Any students? No. You're teachers. This is at a level which is not meant for the chairperson and for this thing. I've kept it at a level which is at my level, so that's why I'm looking for people of and no students. Everybody is a professional. All right. Nobody. There are a couple of people. So उनको आगे ले आओ यार. ठीक है. We will make you the guinea pig. No, we will not. We will not. We will not. Take it. Alrighty. All right. So what we're going to do is we're going to walk through these cases very quickly over the. It's a little animated, so we can do this. PH 7.32. So this may not be Venkat correctly picked up. This is just an illustrative case. You can object, sir. Number ठीक नहीं है. Number ठीक नहीं है. मुझे पता है क्योंकि मैंने ही डाला है. So they are not real cases. So please do not object to the fact that this doesn't match. This is just to illustrate a point. 7.32, PCO2 32, PO2 80, bicarb 60. First step. So first step is, that's what we are saying, 7.32 acidotic. Then, it has to be interactive, otherwise we'll, no point. Why, okay. So metabolic acidosis because the PCO2 is less. Then next step. Next step is compensation. So what is the compensation for metabolic acidosis? What formula? Winter's formula.
Okay, how do we calculate that? Mostly that's the same formula which we use. It comes around 32.
Or you can use the last 2 digits of the ABG. That's a cheat thing. So 7.32, the PCO2 should have been 32 plus minus 2. If it is not there, then you have a problem. So here it is obviously pitch perfect because I made the slides. So this tells you what the diagnosis is. So compensated metabolic acidosis or just plain metabolic acidosis. The word compensated need not be there. So simple. So as we go, so we will do this a few more. We will do about 5 or 6 of this, and then we will leave it to Venkat to trouble you. All right.
Okay. Yes, go ahead. Acidosis, metabolic. Then what was the compensation expected? CO2? 32, but it is 38. What does it mean? Some amount of? So this doesn't look like a simple metabolic acidosis as the previous case, but the CO2 was higher than the expected one.
So this is a metabolic acidosis plus respiratory acidosis. All right, great. We're all on the same page now.
Okay, pH looks mildly acidotic. Okay, then CO2 should be for that 25 bicarb. Which one is the primary cause? Yeah.
Correct.
So this is the case when actually Dr. Ram did the same exercise last time. I was just working through. Then I said, I have 2 components. Any inputs in this? The sentences he made before this session. Anything? This looks normal. Suppose I have a bicarb of 25. Again, I go to 1.5 times plus 8. How much it will come? Around somewhere 40. The CO2 is on the lower side. Is the bicarb in acidotic side? So is this the primary disease is respiratory or a metabolic? We have said acidosis. Is this a respiratory or a metabolic? Why are we saying it is? So if the the CO2 is less than expected, what it should be? It should be a respiratory alkalosis. It cannot be respiratory acidosis. But the pH is on the lower side, then was 7.35. So I just
So-
gave a rank to Dr. Ram. I
No.
said,
So what he didn't pick up, so the question is this numbers right? So validity no. So the answer is no, it's a typo error because look at what the calculation on the expected PCO2 is. What have I used for? PCO2 is 1.5 times the bicarb of 16. So this is a typo. So obviously, or in real life. So here when I've used the calculation, so I've used the bicarb of 16, not 25. So it's a typo, or it is an illustrative case of telling you that it doesn't make sense.
So-
Don't interpret the
yeah,
same.
so suppose it's not a typo and if it is 25, then probably the validation comes.
Validation comes. And it's not to be.
You cannot have bicarb on 25 and CO2 on 24 and your pH dropping to 7.34. And we have a steps of validation. So maybe the numbers are invalid or there is a typo error. It cannot be a routine one.
Absolutely.
We didn't relate it. This
We
is a
didn't delete it
deliberate attempt.
deliberately so that we can illustrate this point that what you are seeing is a completely wrong ABG. So the first thing that you should, as Venkat picked it up, is that it was 16 bicarb, not 25. Hence a typo, and or it's a wrong patient or a wrong interpretation. I refuse to interpret it further. The only thing about this thing is that when you use an ABG to see the bicarb, remember the ABG bicarb in an ABG is a calculated value. It's not a measured value. So whenever you want to measure the validity of a thing, it has to be a measured bicarb in the lab. So if your ABG machine automatically does not calculate the electrodes that it has is a hydrogen ion, PCO2 and a PO2 electrode, it does not have a bicarbonate measurement. So whenever you check validity, the bicarbonate has to be imported from your biochemistry lab. So that is very important to understand when you interpret this case as to say this thing. So if you were to use bicarb as 16, then the answer is that the PCO2 is less than expected. So it is metabolic acidosis plus respiratory alkalosis. But if you were to use bicarb of 25, then this is an invalid ABG example that we have given, which is what we wanted to illustrate. All right. Go ahead. Yeah. But what is important is what Venkat did here is that when you look at this ABG, you have to say either Dr. Ramasubban is stupid, which is what he said, all right, or it's a typo. So I will take the Dr. Ramasubban is stupid compliment and leave the typo as a this thing. But what
No,
the fundamental?
I wanted to understand whether it is a deliberately done or it is a typo
No,
or
I'm just kidding.
It's a wrong mathematics.
No, it's wrong mathematics.
Simple,
when
it can
but
never
I don't
happen.
think-
If you go on our app, there's the world's first app which will tell you your ABG is wrong.
But I don't think we could have done a better job of illustrating to you guys
Perfect.
this thing that we have done, isn't it? So congratulations to both of us for doing that. So sometimes errors makes you look better. So this one.
so again just interaction. pH looks on acidotic side. Just interact. So
Uh,
which is the acidosis? Looks more respiratory. What is the change from 40 if we take an average number? It is at 10. So when I have an acute change in 10, what is the bicarb change I expect? 1 in a situation 1, 2, 4, 5 or whatever formula we use.
All right. Here is the question that I, as a clinician, you should not interpret it anymore. Because this concept of whether this is acute or chronic, a lot of it is historical. So if you don't know, if this is somebody you switched on, put him on a ventilator just now is a different issue as compared to somebody who's having a massive anxiety attack is a different issue, or somebody, what is the history, it depends on that. So always, that's why the ABGs are always to be solved as a clinical case and not to be solved as a this thing. But as an illustrative one, this is a good example of the fact that this, if it is an acute one, the bicarb should have gone up by 1 millimole and it's gone up by 25. So it doesn't look like a chronic respiratory alkalosis. But you can use a change in pH formula first. If you want to make it a little bit more complicated, if you don't have a history, you can use the change in pH formula to find out how much the pH has changed to find out whether it's an acute or a chronic process. All right, next one, almost similar.
So again, pH, is slightly acidotic side. What is that we think is a respiratory or a metabolic?
That's right.
Respiratory. What is the change? 20. What is the change we expected if we continue to the same case of acute?
2.
2. So what should be my bicar?
25.
Maybe 24, it is 26. If I start at 26, it may be 28. But what is my bicarb here?
32.
So it looks higher than that. So what is this? Is it a pure compensation or something else added?
No. So this is why the history is important. So this is not metabolic alkalosis. So this is a chronic respiratory alkalosis. Is that what we are trying to highlight here? Is the fact that the bicarb has gone up by 4 millimole for every 10. So therefore, this is a chronic respiratory alkalosis that is going to be a primary chronic respiratory acidosis rather than a acute respiratory acidosis is what we are trying to highlight here. Same thing now. Now this is now he has already solved it. He is a future AI. है ना? See, you solved this before. You're not able to get his attention. So anybody, go ahead. So you solved this. You already solved it.
So pH acidotic or alkalotic? Acidotic. Component is respiratory. So rise by 20. And expected rise is probably, if it is an acute, probably 2. If it is chronic, 4 into
32.
2.
So
That
here
means
it is
8.
36. So we are saying that there is a metabolic alkalosis in addition to
Again, pH, acidotic. Component, which is the primary, respiratory or metabolic? Metabolic. So what is the CO2 expected? So metabolic acidosis, the CO2 expected is?
So this is case number 1. So why are we doing case number 1 again?
So we will just go into the one more step. Right?
So every time when you say metabolic acidosis, you're actually, even in case number 1, we should not have stopped there. We should have come to case number 7 and gone back and automatically do a anion gap calculation in all these cases. So in this case, the anion gap is sodium minus 4. Alright, again, one of the important things in anion gap is the anion gap sensitivity of picking up an organic acidosis increases only when the anion gap is more than 10. Alright, so in this case, it's about 20, more than 10 of the upper limit of normal. So that means if your 10 is normal, 8 to 12 is normal. After, if it is more than 18, 20, you are sure this is an organic acidosis. In between, it may or may not be an organic acidosis. So just remember that. But that's the sensitivity of the delta anion gap that we talk about.
Excuse me, can you just go back on the slide?
Yeah.
One
Please do
interesting-
not pick faults here. This is
No,
just
no
illustrative.
faults.
I'm afraid. Right.
So if the PO2 is 80,
Yeah. PO2 is 80.
is gone down by 20.
Yes. AA gradient we have not come.
No. The CO2 would reciprocally change.
So yes, sir is absolutely right. In the sense, if there is an alveoli, it has only space for either oxygen or carbon dioxide. So a PO2 plus PCO2 should not exceed 100. But we don't know whether this patient is on supplemental oxygen.
So the interpretation of
Is
this
on
CO2
supplemental oxygen.
have to be dependent on a decline in O2.
Correct.
That's a very interesting point. Sometimes clinicians don't treat.
Absolutely, sir.
But I've seen it world over that we don't relate this CO2 relationship with oxygen. That's a very important point that we need.
Absolutely. So again, without a history, without a full temperature on the ABG, what the PO2, what the oxygen flow is going on has to be mentioned. Otherwise, the interpretation becomes always problematic. Thank you very much, sir, for highlighting that.
Again, just an interpretation. Acidotic, predominantly. The same case of a 16th of metabolic, and there was a compensation, and now the anion gap is 10. So it looks like a normal anion gap metabolic acidosis. Again, pH acidotic, predominantly. Again, we have a.
I think this is some. All right, sorry. All right, so this is in this situation, what we are trying to illustrate is the stepwise is once you calculated the anion gap as, so going back to case number 1, came back to case number 7 and coming back to case number 9 to illustrate that the step doesn't solve by doing case number 1 and saying metabolic acidosis. Is it anion gap or non-anion gap? If it is high anion gap or this thing, calculate the delta gap. So in this situation, the delta anion gap is 22 minus 16, which is 6, and the delta in change in bicarbonate is 14. So what has happened?
So what is exactly we're trying to do is, we said कि high anion gap metabolic acidosis HAGMA or a normal anion gap metabolic acidosis. That's the first step. So if I have a the anion gap which is 22, and then I wanted to see whether there is any other problem, so we need to have a delta gap. So what so did is change in anion gap, that was of 6, and change in bicarb, that is 14. The 22 came from the anion gap, and the 16 came as you took as a normal
Normal anion gap. It used to be 12. You
12.
can take it as 10. So delta anion gap is 10 and delta bicarb gap is 14.
So what are the condition where you can have that kind of corrections to make it 16? Let's say normal you have taken as a 12.
So for what disease, for what, say, if this is a patient with CLD and an albumin of 1.5,
Yeah.
do we correct it? Is the anion gap corrected for? So yeah, so what he's saying is, why have I taken the anion gap, corrected anion gap as 16 instead of 12 is maybe there was a hypoalbuminemia in this patient. So what is the correction for every 1 gram decrease in 2.5 increase in anion gap? Is that what you do for this thing? So maybe that is what the reason is. So here, whenever your delta anion gap has come down to about 6, is only about 6, but the bicarb has come down significantly more. So there is a combination of both a high anion gap and a non-anion gap metabolic acidosis in this situation. All right, so we'll just one case on, all right, this one, and then we'll go to the case 5 cases because
pH is on alkalotic side for a change. What are the reasons for alkalosis? Respiratory or metabolic? Respiratory. Again, there's a drop by 15-20. So what is the expected SCO3 there? If you take 2 in an acute condition also, 15, maybe 3 or so. So the bicarb should be dropped by 3. 24 minus 3 is around maybe 22, 20. So, but the bicarb is 16. So what is that component talks about? There is initially one is respiratory alkalosis, but there is a add-on metabolic acidosis also.
and that's a high anion gap metabolic acidosis. All right, so now we'll go to the cases. I'll do this one and then the next 4.
We will continue the same way.
All right, so 48-year-old.
So
Go ahead.
just before we go to the cases, the points which were made, we will not treat numbers. Okay? We ensure the sample has been collected properly, the heparin has been thrown out with a proper flush, and it has been taken in an ambient temperature, has been transferred in a quick time, and the report has been collected with the calibration of the machine. There can be error in any of them. That's what ma'am was trying to point out. After this, when you get an ABZ, always not just look at the numbers. What I have seen my postgraduates, my junior clinician, write the ABZ numbers in the case sheet. And then they interpret and say this is a metabolic acidosis, high anion gap, and they sometimes say there is a 1 or 2 add-on things as we discussed, another non-anion gap metabolic acidosis. But does this help my patient? No. How will this help my patient? Just interpreting that ABZ. I need a clinical context to link the etiology of that reason. If I say metabolic acidosis, high anion gap, I will say whether it is a ketone or it is a lactate or some toxin which is causing this, and how do I treat it? So if I don't go there, then my ABZ interpretation has no value. So what Dr. Ram did from here is, we will have an ABZ interpretation and I will have a clinical context linked to it so that I will have a disease to treat so that my ABZ will get better. So we will go through that.
All right, alcoholic man found unconscious in his apartment, soiled with vomit. He was last seen at a party 6 hours earlier last night.
So just interpretation, pH, acidotic, all we agree? Okay, then what kind of acidosis is this? I think the bicarb is on the lower side. So it is initially looked like a respiratory acidosis. So with that 65, what is my bicarb expected to be? Is it acute or a chronic by the clinical context? Looks like an acute. There is a rise by 25. So what is my bicarb change expected to be? Not 10. Why 10 plus? Every 10 we rise by 1.
1.
So maybe 25, 2.5.
2.5.
So from 24, it should be 27, 28. What is my bicarb? So what does that mean? So I have a respiratory acidosis. There is also add-on metabolic acidosis. So now we are here, okay?
So
Let
you
me-
happy? Are you happy with that diagnosis, respiratory acidosis, metabolic acidosis?
So now, yeah, the second step is we'll go to the anion gap. So the anion gap is 16, which is corrected with an albumin, which we were talking about. If my albumin is less than 4 and the difference, suppose it is 2, I take 2 into 2.5. That should be addition to your existing anion gap. So that comes to a 22. Next slide.
So what is the next step after this?
So I have a high anion gap acidosis. I have probably a respiratory acidosis. How do I say it is a purely a high anion gap acidosis or something else is there? Delta. Delta anion gap I will take and delta bicarb gap, and then I will see my differences between them. So we'll go to the next.
So delta gap is 8. So there is a concomitant metabolic alkalosis also. So is it triple acid base disorder that you have interpreted? here?
Now this is interpretation of ABG. Now what is that I am talking about which is missing? Is this enough for treating my patient? This is just a numerical corrections which we are talking about with some algorithms. But what is that I have to answer? Why respiratory acidosis? What is the cause for my high anion gap metabolic acidosis? What is the cause for my metabolic alkalosis additional? I have to answer those questions there. So what will be my reason for respiratory acidosis with this context? Ethanolic, intoxication, hypoventilation, probably or some amount of aspiration, we don't know, but that may be the reason for that. What is my cause for your metabolic acidosis in this patient? Okay. What are the other things there? There can be an aspiration, there can be other things, or there can be a toxin there, which I don't know. And the other point is, what is the cause for metabolic alkalosis addition?
Vomiting.
So ongoing continuous vomiting, GI loss.
Yeah.
So I have to probably 1, 2, 3, 4, 5 clinical context so that I can treat all of them together in this context.
So for identifying one more step, what is the one more thing you would have ordered after the high anion, after the delta
What is
gap?
the generally what we do? I wanted to know the metabolic acidosis hagma cause here. Okay, lactates are normal. Ketones are negative. Yes? Osmolar gap.
Very. So then you want to find out whether it's just ETOH or ETOH plus something else that he has had. Yes, sir.
Creatinine 2.2.
Correct.
So renal failure.
So that is metabolic acidosis. Why did anyone get?
Maybe yes.
Yes, that is
And
also-
much more
that is-
important than lactate here because
Yes.
2.2 is a chronic situation. This
Yes.
fellow
Possible.
will be in acid. The question, how many would give soda bicarb in this patient? pH of 7.17, less than 7.2. Sure, none of you would give soda bicarb?
So predominantly respiratory acidosis.
But pH of less than 7.2?
Most of us would
But
ventilate.
pH of 7.2, American Heart Association says would be an indication how many would give soda. Because I know a lot of physicians would give soda bicarb, which should never ever be given. In Marathi, soda means soda bicarb. Please soda bicarb because there is no question. One reason is CO2 is high. So it would add and that would be doing really bad.
True, absolutely.
All right. 22-year-old RTA shock, large volume fluid resuscitation admitted to the ICU. Cryptic case, not a quick clue as they call it in Crossword.
So the ABC is there. What is the interpretation? pH? pH? Acidotic. Possible cause of acidosis? Initially to start with metabolic. What should be my CO2? 18 into 1.5 27, 20. What is my CO2? What does it indicates?
Respiratory.
Respiratory acidosis. So there is already an indication, sir, previous slide. So there is two components here. We were talking about one is metabolic acidosis, and when we calculated there is a mixed metabolic and respiratory acidosis. That's there the first step. Now what is the second step we go forward?
Respiratory acidosis.
So we'll go to the NAND gap. Now, okay, once we come there, then probably what are the causes of the metabolic acidosis here, acidosis in this situation, clinical context?
So what is the anion gap? We've calculated.
No, we will come to that, ma'am, in a step. So what is the anion gap first? 135 minus chloride plus bicarbonate, almost 2 or 3. So
Four.
it is 4. So is it high or normal? Normal?
Low.
Low.
Very good.
Very
Very
good.
interesting to pick
So-
up. That's a low anion
So
gap.
what is the normal anion gap? So it's a low anion gap. So again, that gives a clue. Acidosis with low anion gap. We'll go to the next or we'll ask question.
Yeah, so then why, if you have non-anion gap
One
acidosis,
point
the
here.
next step is
One point here. Potassium is 3.8.
Yeah.
This should give some important point. Anyone?
Mhm.
With metabolic acidosis, you can never have low potassium.
So what is the correction for
So the-
potassium for metabolic
So the,
acidosis?
yeah, so the question is, there are only few conditions where you have metabolic acidosis and hypokalemia. RTA is one important point. So if one sees low potassium in metabolic acidosis, RTA would be a
So
very important point.
that's another clue given in the last line. So what is that reason why we actually got a sodium, potassium and chlorides? So we are talking about a urinary anion gap. So the gap between them.
So this is the interpretation that we did. Low anion gap metabolic acidosis, gap is only 2. Winter's formula, respiratory acidosis and a urine anion gap is negative. So a negative urine anion gap is because of what reason in this patient? With a low potassium. So that means you're, and the hyper, so that, let me put this question as this way. 3 questions. This is a quiz. So this is no longer interpretation. We have gone beyond interpretation.
What are the causes of low anion gap metabolic acidosis in this particular context? Possible causes. Chlorides, but low, it will come normal. Nagma is the common pattern which we say, but low. What are the causes in low? So one of the causes will be hypoalbuminemia. But what is the, in this context, why you say there will be a low albumin with such a polytrauma, large volume resuscitation? So that's when we have a massive blood loss and you have supplement with massive blood volumes in the form of saline. That can be one reason. Then there was a.
But let's ask the quiz. What is the cause of a low anion gap? We can only answer that if you answer, give me at least 2. So one, the exam question for DM is obviously lithium toxicity.
What are the other possible causes?
So this is a patient with say multiple myeloma. So monoclonal gammopathy can be there. If you give a lot of calcium, blood products, calcium can cause a high calcium can cause it. Okay, and high magnesium, hypermagnesemia can cause a, which we don't make. Calcium and magnesiums can go. So in a trauma patient, probably blood, some calcium is, maybe some calcium was given or we don't know in this thing. What is the cause of a negative anion gap? That is also an exam question. The only, what poisoning causes negative anion gap? Bromide or iodide intoxication. So these are all standard stupid MCQ questions, but okay. What is the cause of a negative urine anion gap? Sir already told one of it. So diarrhea, proximal RTA, and one cause in this patient. This patient can be explained by only one thing: large volume sodium infusion with large volume chloride infusion. That means large volume hyperchloremic acidosis because of normal saline. So this is a abnormal saline in this patient because this is caused both high anion and normal anion gap metabolic acidosis with a low urine anion gap as an example of a high sodium infusate and a high chloride load which is causing a hyperchloremic acidosis, and probably trauma, that is what is causing the respiratory acidosis. His breathing is getting flooded, and but oxygen A gradient is normal, so this is a primary acute respiratory acidosis. Maybe he requires ventilatory support. So the treatment, as Venkat is rightly saying, is to change the normal saline, all right, to a low chloride containing fluids, and then take care of the respiratory acidosis by probably initiating ventilation or thing. So this is the final diagnosis: trauma leading bleeding and dilution leading to hypoalbuminemia and low anion gap, saline resuscitation leading to metabolic, trauma and pain leading to hypoventilation is what we said. All right, we want to do, or we go to stop? Last case. Do you have time, or should we stop, sir?
Continue. Moderators.
Whatever. Sir. One? Okay. All right. So if you're interested. So 50-year-old female with recent onset of hypertension. Admitted because sodium is 150, BP was very high, so the ICU admission. Otherwise, I could have made this a medicine admission also.
So I think just for interpretation, pH, alkalotic side, predominantly metabolic alkalosis. Then there is an electrolytes. That is all the clue.
We all talk so much about Winter's formula, but what's the compensation for metabolic alkalosis? Metabolic acidosis is Winter's formula. What is the compensation of respiration for metabolic alkalosis? What's the formula? 0.7 into bicarb minus 24 plus 40 plus minus 2. So 0.7 into bicarb. So in this case, 0.7 into bicarb is 32 into 0.7, which is 24. Minus 24, which is 0, plus 40, which is about 40, plus minus 2. So the respiratory appropriate is 44, which is okay. All right. So for metabolic alkalosis, 0.7 into bicarb minus 24 plus 40 plus minus 2.
So that component is taken care. There is no problem with the respiratory component. Now coming to the purely a metabolic alkalosis. So hypernatremia, hypokalemia with alkalosis. So what is that initially you will give with a history of hypertension? So that gives a clue that probably we are dealing with a primary.
But for interpretation, you need to say that this is a chloride. So chloride resistant because urine chloride is 45 and urine potassium is high. So
that gives a clue.
So the question can be framed as: what are the causes of chloride responsive metabolic alkalosis, or what are the causes of chloride resistant metabolic alkalosis? Obviously, the quiz is going to get complicated as we go on. You thought that it will get easier?
The initial easiest, but in projected like it's not as.
Anybody? So first is
Responsive or be all of them. See, when we say chloride responsive, when we supplement saline and they get better, but how do we get a clue from where? And what are the causes? There will be many causes, right? Any volume depletion state where you supplement normal saline, they get responsive.
So chloride responsive means that you're losing chloride and potassium. This thing that's basically vomiting, diuretics, low laxative abuse, and so on and so forth. High potassium, depending on the BP. If your BP is high, as in this case, it's a mineralocorticoid excess, as you rightly put, sir. And if it is low or normal, then it's a Gittelman or a Barter's syndrome. So it is basically the algorithm will go metabolic alkalosis, chloride sensitive, chloride responsive, non-sensitive, and blood pressure normal or no. So in this case, the final diagnosis with hypertension with mineralocorticoid excess and hypokalemia, most likely an aldosterone secreting adrenaline. So this is how, as we will stop here for the sake of time. We have 2 more cases, but we'll stop here. But I think the message is that, as Venkat very beautifully put it, interpretation is the first skill that we need to have. A second skill, which is very important for a physician practicing in intensive care, is to be able to put 2 plus 2 together, or use AI to put 2 plus 2 together, but use some kind of, if not artificial intelligence, some native intelligence to put 2 and 2 together, to put it into a clinical context. So that's what we tried to do. Hopefully, it was fun, and hopefully it was interesting. Thank you very much for your kind attention.
Thank you, Suresh sir and Venkat sir. This was one of the most interesting and interactive session of the day. Now moving forward to one of the most difficult part of ICU, that is communication. So For this, I would like to call Dr. Gunjan Chanchalani, madam. And the topic is opportunities for communication in ICU. Madam is Director of Critical Care Medicine at Wockhardt Hospital, Mumbai. Over to you, madam.
My slides, they are not even here. Okay. Good afternoon, everyone. And it's afternoon, it was supposed to be morning. Thank you, and it's always an honor to be a part of Mahakriticon and having tough topics. So my topic here is communication in ICU. What are the opportunities that we have? So it is the opportunities and how we are supposed to use those opportunities in the right sense is what I'm going to speak about. I still have my slides. So as we all know that when we are in an ICU, it is a very complex scenario. There are multiple factors which are there. There are multiple number of people which are there. You face people whom you don't know on a daily basis. You face your colleagues. You face your other department consultants and colleagues there. You also face the relatives, which may be a different scenario. Plus, you have the patient himself. There is a lot of anxiety. There is a lot of emotional outburst. There is a lot of misunderstanding. It is a completely dynamic atmosphere which is there in an ICU atmosphere, ICU environment. I still can't see my slides. Okay. With a lot of people and a lot of emotional outbursts that are there. And when we talk of communication in the ICU, the communication can be with your own colleagues when you're giving handovers. It can be with the consultants in your team or beyond your team, between the other departments that are there. Then with your technicians, nurses, everyone. And most importantly is the communication which we have with the patient and the next of the family. Now, when we talk of communication, what do we really mean communication? Communication is when we are mutually exchanging information between two or more people. This is just a simple definition, but we need to understand that communication is always two-way. It is dynamic. It has to be continuous. It is receiving and giving information. So I'm just here probably when I'm communicating, it is a one-sided information that I am giving. So it is not really a communication. It is a lecture delivering. The last lecture probably was a good communication skill, which will lack in this because it's a lecture delivery. So as I said, there are a lot of ways that you can communicate in the ICU. One is a verbal communication. Then there is a non-verbal communication, which we often do with our patients. A simple smile when we greet them in the morning when we are about to wean them is something which they are looking forward to. A written communication to patients who are on tracheostomy, who can't hear, understand, they try to write and communicate. Then there are various visual tools which are there. I wanted to start with the communication with the ICU patient because this is what we never do. Why we never do is probably because we do not think that our unconscious patient needs to be communicated, or a patient who is delirious probably is getting delirious because we are not communicating. So that is where we have our own limitations, and most importantly is the time. We don't have the time or the bandwidth to sit there and communicate with a patient who has limited understanding to tell him his scenario. And often we think that our patient probably will not understand what we are trying to say. His cognitive function is not adequate. So when I put that picture there, it is not to blur the patient. It is to tell you the look of the ICU from the patient's perspective. A patient who's lying on a ventilator there, probably about to be weaned or not about to be weaned, you have given a sedation holiday, and this is the look that the patient has. A completely blurred look, doesn't know what is happening, has a complete time cutoff with what happened as the starting point and where he is now. He probably would be not having his support aids, a visual aid, a hearing aid, does not have the enough cognition, has received a lot of sedations, delirium, or painkillers which may have obtended his understanding. He has pain, he's restless, he's obviously anxious. So this is what actually the patient is looking at. Okay, what we are looking is it's not a very clear picture. But then there are studies which say that even an unconscious patient, if you communicate, they can understand. They do understand what we speak. And this is a trial which was published in 2023. If you see, it is not a very old trial. It is a recent trial where they see that communicating with an unconscious patient is also important. We just go, we give a pain, we say, oh, just, trying to localize, not yet awake. But probably he's still able to understand is what the study has proven by various amounts of tools that were used. So increased verbal communication with these unconscious patients in this study has shown to decrease fear, it has shown to decrease anxiety and also decrease the amount of delirium, and probably a lot of the post-intensive care cognitive impairment that happens in these patients is what is being now researched as a part of communication. On an average, it has been shown that the nurses and this is an abroad study, not in India, they say that nurses spend only 5% of their time in communicating verbally with the unconscious patient. So when they are giving position, just telling them, I am turning you. This is not a practice in our country. This is abroad. And when they include all these points, also they say it is only 5% of their time. Imagine the amount of time that we are giving in our country. And obviously the doctors are spending much, much lesser time than what the nurses are. And probably just on the rounds to give them a pain. So in the ICU, when we are looking at the patient, we need to acknowledge not just the conscious patients, but also our unconscious patients. Maybe they are on sedatives. Maybe we understand their disease processes. They have their lot of barriers, but we need to understand them. But yes, there are other type of ICU patients also. There are patients who are clingers, like when you have weaned them off, they are completely anxious. They will cling to you. There are entitled demanders. There are manipulative rejectors. There are self-destructive deniers. There are various kinds of patients also which are there. And this is defined in 1978. Probably today you will be sitting here when I speak these names, you may probably link one of your patients there. But if we cannot do verbal communication, at least we need to look at these alternative communicative tools that are there in our patients, and there are various. There are picture formats. There are these auto speaking tools which are there, which are the video kind of things where you put a button and the communication happens. Then they can point out to a keyboard to say what they want. There are small short words that are there, and just holding hands, sitting beside them for a few seconds, saying a hello, probably will make a huge difference to their outcomes. Again, the time becomes a biggest factor here when we talk of this. So some rules which we need to understand when we are communicating with the patient at the bedside, or even when we are communicating amongst ourselves at the bedsides, the way we communicate, the amount of volume that we use or the language that we use will probably be registered in that patient, even in that semi-conscious state or unconscious state, and would create anxiety in that patient. So most importantly, when we communicate, is we should have the empathy. It should be non-judgmental, patient, a tolerant hearing, a direct hearing. Probably even I do that at times, and I have my ICU students here, and they will know it that I have outbursts at the bedside, which probably is not a good thing, assuming the patient is unconscious. But after I read the trial, probably I will be doing it much lesser. But we need to, the way we communicate at the bedside is a very important factor, and we need to set these clear limits. Even when we are speaking to our consultants come and outburst at us, or sometimes we outburst saying you are wrong. But that wrong word to that patient who's in a, even if he is conscious or unconscious, is a huge wrongdoing to him. And at times we may try to bring in the family to communicate. Next, informed consent. Informed consent from the patient in the ICU in our country is probably a big question mark today. We don't really go and communicate with them about what they are going through, what is the procedure that they are planning to go through. Even they are completely conscious. A patient with acute myocardial infarction is completely conscious, and we are planning for an angiography and an angioplasty. But how many of us really go and tell him what he is going to look forward in the cath lab? We just tell him, okay, we are taking you to the cath lab. We don't really disclose their information. We don't, assuming they don't have the enough competency and the understanding on the voluntary list. But this is not what is there, and probably it is time that we change it in our country. What we should not do at the bedside is we should never demonstrate a lack of competence. We should not disagree on treatment options in a harsh way with our colleagues. We should not criticize our colleagues, never be pessimistic, because all of these will raise patient anxiety. And if possible, we should get the patient family to further communication with the patient himself. Next important, which we do on a daily basis, I don't know, the slide is not moving, is communicate with the family. Next slide kar doge kya wahan se? It's not moving. Okay, thank you. Next is communication with the patient family, which we do on a daily basis. And I have put a lot of extensive slides, but I think I'll have to cut it down because we have just 7 minutes. So when we talk of family, where family can include anybody. It can be the loved ones, then could be a guardian, could be some proxy caregiver, anybody who can be the family. A family meeting is to prevent miscommunication and to address the emotional distress that they are going through. And during COVID pandemic, there were family liaison services which were there, which used to help because of the time-bound thing. They used to help communication between the doctor and the patient. So what are the barriers that we have? Of course, when a patient comes to the ICU, it's a new thing. Not every day. There are patients or their family members who are in the ICU and the scenario, they have never heard of these terminologies like anxiety and other things. So when you have these family members in the ICU, obviously they have a lot of anxiety because of the unfamiliar surroundings, because of the suddenness of the illness, because of the severity of the illness, and because of the unpredictable nature of the illness that we have also communicated to them. They are not aware what is happening. Next is the noise levels in the ICU. Huge noise levels which can lead to multiple misunderstandings, errors, and there's limited space. So most importantly, when I say this, important is when we try to do a family communication, it should probably be in a separate area and not at the bedside, which is often done. Again, there are various space constraints that we have. The opportunities that we have when we have family communication is one of the initial consultation when they come in. Next is when we are giving a daily clinical update, or when there is any crisis which has happened, the accidental extubation, or maybe a sudden desaturation, or maybe end of life issues that we discuss. When the 10 commandments that we should have when we have a communication with the family member or with the next of kin, it should be first you should identify who you are. Always tell them the truth. Of course, when there is a pneumothorax with a central line, there are a lot of legal issues also involved with it, or communication. So communicating the right way, probably informing them the adverse events initially is very important, and I will not dwell there. But telling them the truth that this is what happened and this is what is to be done. Be simple. Avoid telling them the physiology. Do not tell them what CRP is. Do not tell them, what is acute kidney injury and what is the person. What they are interested is how many dialysis, how many days, will it recover or not. Of course, but explaining them the pathophysiology of acute tubular necrosis is what not they are looking at. Dress appropriately, make enough time. Do not hurry when you say it. Instill confidence in them rather than creating more doubts. Of course, you have to give them uncertainty about the prognostic predictions which are there. You cannot give them all a positive or a negative. You have to give that uncertainty factor which is there. Always work at a team. There cannot be a consultant who's speaking one aspect and the other which is speaking another. Except that they may have some lack of trust because of the 1,000 second opinions that they are taking. And if required, you may have education tools in your ICU which you do. Again, what to do before the meeting is go through the patient records, go through the minor things, go to review all the reports because they will ask you these questions. What you do during the meeting is have proper settings, introduce yourself, introduce your intention. First, always allow the family member to speak because that will tell you what is their knowledge and understanding of the scenario, and also what is their background of understanding itself, what is their cultural background and how much they would understand what you speak. When I tell them stroke, probably they don't understand what is stroke. Okay. Then, of course, when you understand, when they have spoken first, also when they speak first, there is a lot of emotional outburst that comes in and that calms them down itself. Then you give them a detailed medical review or the summary. Wait for them to accept that and look at their reactions, the emotional reactions which it comes. When I look at the verbal cues that they're giving, when they're just looking around, just leaning back, probably they are not okay to accept what you're trying to say at it, currently. Then you discuss the prognosis and what are the goals that the family wants. Does the family want a goal of complete cure? Or the family wants a cure only till a family milestone which is available. There's a wedding next month. I want him to be alive till then. What is the level of family goal that they have? Present them the broad care options that are available. Translate your goals finally into a care plan. So, okay, this is your goal. You want a 1 month survival for this 80-year-old grandfather. Okay, this is the treatment plan which we will do, which will not make him suffer and which will give our goal also. And ultimately important is to document and discuss. And currently in current scenario, we have verbal, video, audio documentation also. Communication always has to be regular. Preferably designate one person from the family who will communicate with you so that there is no multiple hearings and multiple repetitions. Look at the body language, understand them, give information but not the physiology in detail, and reinforce your message. Again, you may face with a lot of problems. There may be difficult relatives. There may be relatives who may have frequent communication demands. There may be people who don't understand well. They may be aggressive or accusive family members. Again, keeping calm, listening, having some professional guidelines and giving time. The most important factor is important. Next is breaking bad news. A bad news is something which will alter the patient overall in the future. So when you break a bad news, it is the worst thing, something which we are always scared of. Or probably we try to avoid, because when we go and break a bad news, we always believe that, probably I will be blamed. There will be a reaction which I will not be able to tackle. I may not know all the answers. There's a fear, my own self-fear. Probably today I am vocal about saying I cannot counsel a burn patient. I don't work in a unit with this burn because there is a family personal trauma that I have been through. Then so these are all the fears when you break bad news. Then there is spikes. So to overcome this breaking bad news, there's the mnemonic which is there, which is spikes, which is have a good setting, understand the perception, invite the person who would like to know all the information, give enough knowledge, understand the emotion, and finally summarize in the way. Again, we can use technology like electronic health records and telemedicine solutions. And finally, the interpersonal communication, which we do daily. But again, there are a lot of limitations there, a lot of challenges which come often because of hierarchical challenges. You know, the primary consultant, a senior 70-year-old medicine consultant coming and challenging me with whether I should use NORAD first or dopamine first for a thing. These are all the hierarchical structures that we need to respect, the cultural differences which are there. Again, the opportunities here are during the rounds when we are explaining the rounds. Then there is a handover. Then communication with a referral doctor or even with the coroner or a medical legal case. And then there is, of course, team communication where we have to avoid conflict amongst each other. When you communicate, again, there are graded assertiveness, whether you want to command, whether you want to give only a statement, whether you want to suggest or raise a query or give a preference or a hint. Then when you give handover, the handover tool is the SBAR tool, which is very important and which is very common. I will not go through the detail, but it is here what is important to note is that there is 37% of the medical errors in the ICU are caused by poor communication between the doctors and the nurses, which is to be noted. Then there is 5-step advocacy tool, which is there for communication during crisis when there is a code blue. So when there is a code blue, how do we do this crisis communication? Again, there's a 5-step communication about when there is a crisis, what should be the goal? How we have to put together the whole team working together, keep the communication flowing during them, prevent the crisis in the future and also anticipate it. And finally, when you communicate in the crisis, again, there are two ways of communicating. One is closed loop communication, and other is the flying by voice communication. Closed loop communication is when I'm being given an order and I ensure that I followed the order. So I give a back that yes, I was told to administer adrenaline, I have administered it. Next is flying by voice. So flying by voice is when you're log rolling a patient with a cervical spine injury, probably you're flying by voice wherein everybody is asserting with you that, you know, this method has been used. And communication within an error, I will take only 30 seconds, sorry for this. Communication when there is an error. When there is an error, of course, you should not attack the person, but the problem. Of course, sometimes we do have emotional outputs where we attack the person, but finally the solution is that the error does not happen again. Future directions, there are huge skills. There is also Criticare 2026 where there are workshops on communication skills, so please do attend there. Then there are simulation-based communication. Dr. Ajit took a fantastic lecture. There could be artificial intelligence which can be used for communication, and there are used mobile health applications which are now available for improving communication. It is time we do more research on it, understanding what is communication efficacy to diagnose, identify gaps. There's again a survey which is going on from ISCCM, which you should attempt to understand these communication gaps which are going down, and probably doing pilot programs for the new approaches. Finally, thank you so much for this, and sorry for the extra time. Please do attend Criticare 2026. Thank you so much.
Thank you, madam, for the explicit topic. Thank you.
Any questions?
We will take question at the end of this session. And now, moving to next talk, Dr. Pratik Kolwal. He is on Zoom. So he will present on gastrointestinal dysfunction in critical care. He is working as senior consultant in Arya Medical College and Hospital, Jaipur. Over to you, Dr. Pratik.
Good afternoon, sir. Am I audible?
Yes, you are audible.
Balance versus
Thank you. So I thank you, Dr. Deepak, and thank you, Deepak sir, and thank you, Aunty sir, for this collaboration for this meeting. So I think we are running late, so I'll just not wait for your time. So I'll just put my talk to the slide share. Is my slide is visible?
Yes, visible.
Is my slide is visible?
Yes, your slide is visible.
Okay. Okay. So my topic is gastrointestinal dysfunction in critical care. As we all know that the challenges in mechanical and management of a comprehensive exploration often overlook the GI complications in critically ill patients. The evidence that based on strategies for optimal management. Why this GI dysfunction is important to know. The high prevalence GI dysfunction affects the 60% of critically ill patients, making it one of the most common complications in the ICU setting. Mortality impact was about presence of more than 3 GI symptoms triples the mortality risk, which significantly worsens the patient outcome. As we all know, the GI dysfunctions can relate it to increased event of a sepsis also. Underrecognized part of GI failure is often overlooked in organ failure scoring system like SOPA, leading to delayed recognition of interventions. The gut impact on a critical care is the healthy barrier, that a forgotten organ in a critical care. So that's the healthy intestinal barrier is totally get abandoned by the unhealthy intestinal barrier when the infection of the epithelial cells or tight junction opposition is lost, causing to the decreasement of the blood supply to the intestinal part of the mucosa and a submucosal level. So the critical illness can disrupt the nutritional barrier and the immune system and endocrine function of a gut. Diarrhea, vomiting, abdominal distensions, and high gastric residual volume and gastrointestinal bleeding and intra-abdominal hypertension represents some of the features of the gastrointestinal dysfunctions. Despite its critical role in immunity and nutrition and systematic homeostasis, the gastrointestinal system remains the underappreciated critical care assessment. The AGI grading system, which says that the classification spans about grade 1 to grade 4, but the grade 1 is a risk factor presents, and grade 2 the GI dysfunction, and grade 3 the GI failure, and grade 4 a life-threatening failure. The clinical spectrum that moves towards the defining the GI dysfunction and a failure is that the microbiome disruption and dysbiosis that causing the disruption of intestinal barrier system. The manifestations are diverse and interconnected, and the barrier failure increase the permeability of intestinal ischemia and GI bleeding. The challenge is that the lack of standardized biomarkers are still present in the complicates the accurate diagnosis and real-time monitoring. What the real-time frame and the 2020 says that a research article which says that underlying mechanism causing the altered bile acids, impaired GI mortality, and the increased intra-abdominal pressure with the breach of mucosal integrity causing the clinical effects like malnutrition, cholestasis, gastroparesis, GI ulcerations, GI infections, lactic acidosis, and bowel edema, which overall lead to the life-threatening conditions. As we all know, the massive GI bleeding, sepsis, abdominal compartment syndrome, we all get abandoned in the ICU when the sepsis overruled over that. The gut critical illness, to know that damage can originate in the gut lumen or a site outside or of the gut, or it may result from more than one source. Regardless of the initial trigger, common cause of a gut failure, critical illness include a compromised GI blood flow and the lymphatic dysfunction, which alters the gut microbiota. So the gut in a critical illness, you know that, as we all know, in a non-stress part, our 25 to 30% of the gut flow is towards the splanchnic flow. But when the stress-related factors goes to 100%, the splanchnic flow deprived the most, because to have to flow towards the heart, brain, kidney, and other vital parts of the organ. So the pathogenesis towards the gut underseas in a critical illness is splanchnic hypoperfusion, which reduces the blood flow and leads to intestinal ischemia, epithelial injury, intestinal cascade of dysfunction. Epithelial damage, intestinal epithelial cell death occurs with regeneration compromise the gut protective and absorptive function, which get disrupted towards them. And the barrier breakdown, which causes a disruption of tight junction, increases intestinal permeability, and the leaky gut phenomena. Dysbiosis and the loss of microbial diversity allows the virulent pathogenesis to flourish, bacteria, endotoxins, and translocate. Towards that, as we all know, that our mucosal barrier system get disrupted by outside by the pathogens or inside by the less flow of a blood supply, that the PO2 goes below the 40, as we have already seen our slide. When the PO2 go below the 40, the gut mucosal barrier get disrupted with the mechanism of inflammatory markers, nuclear transcriptions, and systemic cytokine release, causing the MAP and DAM proteins, causing a disruption of a tight junction, causing the flora disruption of the intestinal mucosa. The gut lining that needs to be clear. Why? So, because of the multiple elements of gut epithelial integrity of fertility in critical illness, junctions between the epithelial cells, the microbiota that got translocated from the intestinal bacterial flora to the systemic circulation, the microbial virulence spectrum, that is the low virulence, causing by the innate immunity and the immunity that gets disrupted by the sepsis and a microbial dysbiosis. The clinical features of a dysfunction in ICU is of a gastro dysfunction in ICU is that motility disorder which causing the high gastric residual volume, mucosal injury, pressure complications, and nutritional impact, which causing a feeding intolerance and for malnutrition, delayed recovery, increased infection risk, and prolonged ICU stay. The diagnostic challenge too that we all have now started to decrease the GI dysfunction is that clinical scoring system that we can do whenever you come to the ICU. You tell your resident that is that the AGI grading system is 1 or towards the 4 or GI dysfunction system provides a score, provides a standardized assessment framework. Along with that, you can move around with your ultrasound machine and checking the GRV volume. Is your GRV volume is less than 100? Is that volume is increasing day by day with your nutrition? Is that prokinetic agent is working along with that? The GA ultrasound, the plasma citrulline level, and intestinal fatty acid binding proteins indicates the epithelial injury and advanced imaging section also. So the clinical pearl towards in a one-liner, I can say that no single test definitely diagnose the GI dysfunction. Use a combination of clinical assessment, scoring system, and selective laboratory imaging will collaborate effect and give a patient presentation. So the case study, just I want to elaborate myself and my talk with a case study toward that a person with Mr. J, 58-year-old patient come with a sepsis and shock with a GI failure, and you validate yourself with a clinical retardation on day 4, found that progressive abdominal distension and high gastric residual volume exceeding 500 ml and a GI failure classification met the criteria of AGI grade 3 that I asked with my resident and an initial prokinetic therapy feeding modification I've done with that. And case study with the diagnostic workups and the findings that I do with this patient is that abdominal ultrasound, biomarkers analysis that are intestinal fatty acid binding protein, endoscopic findings to see the multiple stress-related gastric erosions. If they are, then go with the epinephrine injections and the clip management. And the microbe analysis can also the mark dysbiosis with the loss of protective commensals. With the consequences with this sepsis, what can occur in the GI tract failure is that the microbial translocation, which can cause the dead microbes and microbial components to the systemic circulation and causing a disharm or GI dysfunction and a systemic dysfunction. A local response to the blood barrier failure, release of extracellular vesicles, and innate immune response, epithelial cell injury, barrier dysfunction, and lead to activation of neutrophils, macrophages. So with this, with the diagram we previously shown that with this of GI dysfunction, the tight junction can release and cause the microbiota to release in a systemic circulation. How you manage with that? So along with your septic part, you go with the GI motility part, post-pyloric feeding, and systemic management. The management principles of early intervention, early enteral nutrition, feeding strategies, prokinetic therapy, and ulcer prophylaxis that you go with that. So nutrition strategies in GI dysfunction starts with the routine selection of route with the gastric feeding, post-pyloric feeding, and parenteral nutrition that to be reserved if contraindicated to the enteral nutrition. Future dysfunction direction towards that immunonutrition toward the glutamine, omega-3 fatty acids, and microbes. This is a nutrition strategy that acts with a GI dysfunction of sepsis, trauma, and shock patients and a reperfusion towards that. So you don't have to feed your patient, overfeed your patient when there is a sepsis or critically ill patient. Never overfeed. So my recommendation and the clinical expense recommendation is that hypocaloric nutrition, if indirect calorimetry, isocaloric nutrition rather than a hypocaloric after day 3 caloric delivery can increase to 80 to 100%. This is a nutrition requirement for the patient of an ICU patient going for the protein, lipid, and the carbohydrates. And this is the Indian guidelines of a practice guideline for nutrition of a critically ill patient, which shows that how much energy and how much protein requirement to be given to the intensive care unit patients. So start with your 25% on day 1, go for the post-acute phase on day 4, and a convalescence phase in a post-hospital discharge patient. So the managing the complications go with the GI dysfunction is GI bleeding management, for the endoscopic therapy, intra-abdominal hypertension, sepsis from a translocation can be avoided by the broad spectrum antibiotics and surgical consultation. In a future case, what I see in a day 4 and day 6, initiation of multimodal therapy can be given on day 7, a gradual improvement of GI functions and transition from the full volume enteral nutrition to provide the motility and avoid a translocation of the bacteria, successful extubation and transfer to step down unit. The research of an emerging part is nowadays going to biomarker development, microbiome modulation, novel therapies, and targeted therapies promoting the epithelial repair of enhancing a barrier function, modulating the intestinal inflammation, and show a premised preclinical studies, scoring system integration, advocacy of incorporating GI dysfunctions of a matrix into the establishing organ failure scoring system like Apache and SOFA scoring. So the takeaways from my clinical practice and the GI dysfunction that you go in your ICUs and outside the ICUs in your hospital or after the post ICU discharge is that recognition and a prevalence of a GI dysfunction in common and serious and frequently underrecognized ICU patients. Early intervention matters to the implementation of evidence-based management strategies significantly improve the patient outcome and reduce the doctor's cost. So nutrition as a therapy and team-based approach. So GI dysfunction management algorithm is this: assessment phase, intervention phase, and monitoring phase. And gastro dysfunction or management is a summary of all that you can take of this, like a nutrition, first line, second line, and third line, with the start of enteral nutrition and palliative nutrition before 7 days. If enteral nutrition fails, then if the caloric measurement can be done and avoid overfeeding 48 hours. The gut disk motility, infection, and GI bleeding and disorders of perfusion classification. Preventive measures can be done according to the classification, and management can be done to avoid these dysfunctions in the patient of GI dysfunction critical illness patients. So the integrate GI monitoring and advocate for research and education and training to develop a comprehensive education program, train ICU teams in early recognition and systemic assessment and proactive management and GI dysfunction is the main role for alleviating a gut care in critical illness. So in last, I can say that integrate a GI monitoring system to take a daily ICU rounds so that a standardized protocol can be set. So thank you all for your quiet listening and thank you for giving your time. Thank you.
Thanks a lot, Dr. Pratik sir. Now, moving forward to next interesting topic, that is balance versus saline fluid. I would like to call upon Dr. Amol Kothekar sir. He is professor in intensive care medicine and in his Department of Anesthesia in Tata Memorial Center, Mumbai. Over to you, sir.
Thank you, chairpersons, for kind introduction, and thank you, organizing committee, for inviting me here. It's always pleasure to be here in Nagpur. And the topic given to me is balanced salt solution versus normal saline. And this is an age-old or century-old battle, whether to use Ringer lactate, whether to use normal saline. How many are physicians here? And how many are anesthesiologists? So generally, it's a blanket statement, it may be incorrect, but generally physicians prefer normal saline and anesthesiologists and surgeons, they love ringer lactate. So this is an age-old battle, and everybody thinks that I am right. I want to use normal saline because that is the correct. And I think in the previous talk about the ABG, Dr. Suresh has mentioned it is not a normal or a physiological saline. It's an abnormal saline. So let's say why it is abnormal, and let's try to get some evidence-based practice or evidence-based recommendations which fluid we should use. Now, before that, let's try to understand some physics and physiology. So don't get scared when I say physics. It's physiology, I can say. So my question to you is, what is the normal pH at 37 degrees Celsius? So is it 7.4, is it 7, is it 6.8, or none of the above?
None of them.
7. Any other answers? It's 6.8. You're right. Absolutely, Dr. Shaswati. Thank you. So pH, so neutral pH is 7 at room temperature 24. When you talk about 37 degrees Celsius, the neutral pH is 6.8. Okay. So what does that mean to us? It means that when we say neutral pH, we are talking about chemically neutral pH. It is 6.8 at body temperature, but what is the normal pH for body? It is not 6.8. If somebody has a pH of 6.8, you already know the patient is already gone, isn't it? So pH of body is 7.4, which is slightly alkaline. And why it's alkaline? Body tries to maintain alkaline pH. How it does that? By having more of sodium and less of chloride, right? And this is the basis of strong ion difference. So if you understand this, then you know that any fluid which contains equal amount of sodium and chloride is acidic to the body. So when you're giving a normal saline, you're actually infusing acid in the patient. So when you infuse acid, what happens? So which organ will work?
Kidney.
So kidney has to do overtime to throw that extra chloride off. This is one famous quote by Dr. Henry Mencken. So life is not a struggle against money or anything, it's a struggle against hydrogen ions. Every day we struggle to excrete hydrogen and chloride ions outside, and the day when the struggle ends, that is the day when everybody is going to die, isn't it? All of us who are going to, or any patient who dies, ultimately the pH goes to the 6.8 or something. So this is some understanding of physiology. Now I have one question for you. If you have a patient with renal failure, what fluid you use? Do you use ringer lactate or use normal saline? What is your preference? CKD patient. Normal saline, and why? Why normal saline? Because you are worried about the potassium, right? So you are worried about potassium might go up. But when we say hyperkalemia, it means potassium of 6 and RLS potassium of 4. So you should not be worried of hyperkalemia in a CKD patient. So I'm not talking from what I'm saying. So if you go by the evidence, this is a study in patients who are not, these are not renal failure patients, these are end stage renal disease patients who are going for transplant. And in this patient, when they found actually the incidence of hyperkalemia is more if you are giving ringer lactate. Sorry, if you are giving normal saline, not ringer lactate. So if you give ringer lactate, less patient had hyperkalemia. So when you give normal saline, actually there is no potassium in it, but it has more chloride. And when the body has to get rid of the chloride, it has to get rid of the chloride along with the along with other cations, and it causes more. It retains potassium, and it causes hyperkalemia. So you might have seen this. So what kidney says? So kidney is not worried about potassium. So what kidney is worried about? It is chloride. So let's see composition of commonly available crystalloids. Sorry, I'll just go back to the, yeah. So this is the composition of commonly available electrolytes. So if you see, there are many options available here. So you have ringer lactate, normal saline. So which of these is close to the plasma? Except for NS, almost all are close to the plasma. Now if you go to, so someone will come to you and say, oh sir, what fluid you are using? No, sir, you should use only balanced crystalloids. And we have best balanced crystalloid in the world. And if you see all the studies of balanced crystalloids, you see all these studies, they had always compared with normal saline. All the newly available balanced salt solutions, they will give you 10 studies. You know, my fluid is better. And what is the comparator? Normal saline. How many of you, I'm not aware of any study which has compared a recently available balanced salt solution with the age-old solution, that is ringer lactate. Right? So ringer lactate is there since almost 100 years. This also has come just now. And I didn't find any evidence that I should stop using ringer lactate and use any of the newer balanced salt solution. If you understand the physiology, all these balanced salt solution, they will use some form of buffer. And if you see here, you can have lactate, you can have a citrate, acetate. Ultimately, all these buffers, they had to get metabolized by the citric acid TCA cycle. So whether you give lactate or whether you give acetate or gluconate, ultimately the body has to break it down, and when the body breaks down, then only that will work as a, it will not cause any acidosis. Now let's see some evidence. So there are many trials. One trial in New Zealand, 2025. So they compared plasma light versus normal saline. So again, there is no RL in comparison here. They didn't find any difference in mortality, and there was no difference in renal outcome. This is again a large study, more than 10,000 patients, and they looked at mortality and looked at the renal failure at 30 days. And what they found, that in patients who had renal failure, creat of more than 1.5, in these patients, balanced salt solution was better. Balanced salt solution was also better in patient when admission chloride was more than 110. So obviously it's very logical. If somebody has a chloride of more than 110, it's already a hyperchloremia, don't give normal saline, give any balanced salt solution. Another large study from United States. So they found improved in renal outcome and improved in survival in sepsis patients. So if you look at the data from this study, you can see here, in patient with sepsis, there was a lower mortality with balanced salt solution. In patient with previous RRT, some patient had a severe renal failure in previous admission, previously patient received RRT, these patients, they have a better outcome if you are using balanced salt solution. One study from South America, they didn't find any difference between mortality or renal failure. However, they found that if you use balanced salt solution in patient with traumatic brain injury, they had a poor outcome. And if you see, the mortality was almost double, almost 1.5 times in patient with balanced salt solution compared to ringer lactate. A 5,000 patient study, this is a recent study from Australia and New Zealand, and they didn't find any difference. Again, I said, If you always, when you look at a study, you always look at a comparator. Here the comparator is a normal saline, not a ringer lactate. So if you summarize all these studies, what we understand is the balanced salt solutions are better in terms of mortality and renal failure, except for patient with traumatic brain injury, right? So some studies are positive, some studies are negative, but there is always a trend towards balanced salt solution, especially in patients with sepsis. So obviously this balanced salt solution, they are maintaining hemostasis and they prevent metabolic acidosis, so that's why they're better. Now you will say, okay, that's fine, I use in sepsis. What about the patient with liver failure? I can use ringer lactate for other patients, but what about the patients with liver failure? Now this is a study in 2021, RL versus saline in critically ill adults with cirrhosis. So this is again a secondary analysis of the SMART study which I had shown previously. And there are more than 100 patients in each group and they didn't find any difference in cirrhosis related death between RL and NS. So if you give ringer lactate, it has almost 28 millimoles of lactate. But if your liver is not working, don't worry, muscle is working. Muscle will take care of lactate. You might have some rise in lactate, but you will not have a change in outcome. However, if you are using lactate, you have a better kidney outcomes. Now, as I said previously, many physicians love NS, and if you look at the guidelines of DKA, so what the guidelines say? What is the preferred fluid and DKA? In Harrison, it is given. When I was reading Harrison, it was NS. So it's still NS now. So in DKA patients, again, everybody prefers NS. The physicians prefer NS. American Diabetic Association recommends normal saline, but this is the evidence. So one is the second analysis of a SMART study, salted study, and another is a separate study. Both the studies have shown if you give ringer lactate, you have a faster resolution of DKA, short, and you have a so DKA gets cleared faster, insulin gets stopped earlier. Now, if you go to look at the guidelines, Surviving Sepsis campaign has changed guidelines in 2021. Previously, it was either NS or RL. 2021, they say that we suggest we should use balanced salt solution versus normal saline. Again, normal saline. The evidence is weak. Quality of evidence is low. So recommendation is weak, but this is the suggestion. And patient in liver failure patient, the recommendation is either use ringer lactate or balanced salt solution. Okay, so. And only thing that you should be careful, because in this patient they can have a hepatic encephalopathy. So don't let the sodium fall down. Take care of sodium because these are hypotonic. Now you will ask me whether there is any role of normal saline in ICU. Yes, of course there is a role. The role is in traumatic brain injury. Another important is patient having hypochloremic metabolic alkalosis. In this patient, you should not use ringer lactate. If you use ringer lactate, you will worsen the acidosis. And obviously, patient with hypovolemic hyponatremia. So, to conclude, use balanced salt solution because they maintain physiology, maintain acid-base balance, they reduce renal stress. Avoid these solutions in traumatic brain injury. RL is widely available, cost effective. So some people say we use caution with liver failure, but the evidence says otherwise. Normal saline is safe, but it can cause acidosis and it can cause renal failure with large volumes. So the choice will be individualized based on the patient. Thank you.
Thank you, sir. Thank you so much. And we will take, I think there will be many questions on this controversial topic. We will take question at the end of the session. And our next speaker is Shashwati Sinha. He is Senior Consultant, Critical Care Medicine, Manipal Hospital, Kolkata. She is speaking on perioperative nutritional support. Over to you, ma'am.
Good afternoon, everyone. I would like to begin by thanking the organizers for the opportunity. So I'll be talking about perioperative nutritional support, which is again a very controversial topic in the sense that we know a lot of things which are beneficial, but when it comes to the bedside, there is always a controversy or there is always a difference in practice regarding when to start feeding, how much to start feeding, when to use parenteral nutrition, and so on and so forth. So why is malnutrition important in surgical patients? Because it has been proven to impact outcomes, not only in terms of post-operative complications and length of stay, but can also impact mortality. And the risk of malnutrition is not small. So it is as high as 20 to 50%, and it can go up to 80% in persons undergoing major GI surgeries. So apart from the surgical risk per se, there are additional contributors which the person can come with, like someone with cancer undergoing surgery, somebody having comorbidities or chronic organ failure, somebody who has an inflammatory bowel disease, and sarcopenia, which is being increasingly recognized and which was something which was not given much cognizance in the past. So all of this plus the catabolic stress and the muscle loss which the surgery itself induces, all of this contributes to malnutrition in surgical patients. So there is something called as a surgical stress response, like somebody who develops trauma or somebody who develops sepsis. Similarly, as soon as the incision happens, there occurs a similar mechanisms. There are a lot of counter-regulatory hormones, catecholamines, as well as humoral agents which release a lot of cytokines. And this itself triggers an inflammatory response in the body. And there are a lot of implications related to that. And that is the reason surgery itself induces a lot of stress, leading to hyperglycemia, insulin resistance, and whole body protein catabolism. Now, if we look at the components of perioperative nutrition support, it is multifactorial. Screening and assessment becomes extremely important. Not all patients requiring every kind of surgery require similar nutritional requirements. Rehabilitation is something which is important. It is multimodal. So it is not only nutrition, but also exercise, smoking and alcohol cessation, and a lot of lifestyle modifications which can be done in order to improve outcomes. Apart from that, we are commonly used to the concept of overnight fasting before surgery. And at the drop of a hat, we would like to stop feeding from midnight. So preoperative metabolic optimization and carbohydrate loading, it's come up in a long way as a part of the ERAS protocol, that is the enhanced recovery after surgery. So it forms a major part of the perioperative nutrition support. Postoperatively, how soon to start early enteral feeding and which are the candidates and who are not is important to identify, and how to build up over a period of time. As well as, again, there is a specific proportion of patients who are not candidates for early enteral nutrition. So how to identify and when to start parenteral nutrition, how much to start, all of these are components which need to be addressed. So when we talk about screening and assessment, there are a lot of tools which have been used, but something which is simple to use at the bedside, and I think most of our nutritionists who do it, is the subjective global assessment. It is simple, safe, inexpensive, does not need much of fancy data, and although we know Nutric is meant for patients in the ICU, sometimes it can be challenging and it's not done in a lot of setups. There is a specific nutrition screening related to the perioperative period, which is called as the perioperative nutrition screening. The first step is to look at the BMI. If the BMI is less than 18.5, go to step 2, look at the history of weight loss if it has been more than 10% in 6 months. And step 3, you look at whether the muscle mass and what is basically all of these, if any of these two answers is positive and the patient's preoperative blood shows an albumin less than 3, so this patient should immediately trigger a preoperative nutritional therapy for this particular patient. And as time is going by, there is an attempt to obtain a global consensus for diagnostic criteria. So the GLIM criteria is something which is being proposed, which uses phenotypic as well as etiologic criteria. The challenge with this is, again, in a lot of situations or a lot of setups, actually looking at body mass index formally or assessing the muscle mass in a systematic way is something which is not done, but probably in the days to come, GLIM criteria will be a part of nutritional screening even in surgical patients. It's very important to diagnose sarcopenia because we are dealing with a lot of cancer patients undergoing surgery, a lot of elderly individuals undergoing surgery, and they have a lot of comorbidities. And the earliest screening could be having a low skeletal muscle index if a person is undergoing a CT scan preoperatively because of the primary diagnosis per se. Asking the radiologist to look at the skeletal muscle mass at the level of L3 can give you an idea about sarcopenia. Reduced hand grip strength and slow gait speed. The family might be saying that over the last few days, he's barely able to move around in the house. So all of these could be indicators of sarcopenia. The CT is a gold standard for muscle quantification in sarcopenia. Although the thresholds have been different and they have been identified differently by the Indian guidelines, because of the habitus, the threshold will be different in an Asian population. There are other modalities like bioelectrical impedance, DEXA scan, even ultrasound of the rectus femoris, if it's done regularly in a serial way at the bedside, can give an idea. To look at the muscle function, the hand grip strength, and the 6-minute walk test also can give a reasonable idea as to sarcopenia, and that because that will correlate with a lot of post-operative complications. So when we are talking about prehabilitation, basically what we are trying to do is to improve the functional capacity of the individual to enable him or her to withstand the stressful event. The surgery itself is going to be stressful, and like I mentioned earlier, so exercise to improve physical fitness if we have the luxury of the time, if it's an elective surgery, optimization of nutrition, looking at the habits and encouraging smoking and alcohol sedation. And again, surgery, the looking or waiting for a surgery itself can lead to a lot of psychological strength, and it has been shown that this multimodal approach can increase the resilience against the physiological stress of surgery, anesthesia, and improve the perioperative course. So when we talk about the preoperative phase, the first step would be a nutritional assessment. So there has to be a systematic SOP where the person is surgically, the nutritionist assess, and depending upon the nutritional score, if the person is able to take enough orally and able to meet the nutritional requirements, well and good, give a carbohydrate loading the previous night and 2 hours prior to surgery. Again, caution needs to be exercised in diabetic patients. You don't want to overload a diabetic with a carbohydrate load, or somebody who can have gastroparesis. We don't want somebody to take a carbohydrate drink and vomit in the operating room. But important is somebody who is at a high nutritional risk, whether the surgery can be postponed for 7 to 14 days. It has been said that if it is a severe malnutrition risk, and if it is feasible to postpone it for 7 to 14 days, these are the people who need the highest amount of focus, and try to optimize in terms of oral or enteral nutrition, and if that is not achievable, then supplemental parenteral nutrition to optimize the patient prior to surgery. After the surgery is done, this is when the trick begins. Every morning you ask the surgeon, can we start feeding? No, not today. Can we start feeding? Start plain water 10 ml per hour. Can we start feeding? So this is something. So we need to identify the persons who benefit most from early post-operative enteral feeding. When we know that early oral feeding is unlikely to be started in the next few days, or it's going to be inadequate. So this is somebody maybe undergoing a major head and neck GI surgery for cancer, somebody who has suffered a traumatic brain injury and has undergoing a surgery, maybe a neurosurgery, he or she will not be able to eat orally, and someone who is already malnourished at the time of surgery. So this is the target population, not somebody who, a healthy, fit person who's had a fracture and has a surgery, and this person probably can wait for even 5 to 7 days before he or she can eat orally. So targeting this population can lead to faster intestinal recovery, shorter post-operative stay, and fewer complications. How to initiate EN? Usually a standard whole protein formula is what is recommended by the European guidelines. The Indian recommendations are slightly different. Yes, they recommend the same, a standard protein formula, but there is a subset of patients who will have some gut intolerance. In them, we can think about semi-elemental. Again, it's good not to be very aggressive, start really slow and aim to achieve the target within 5 to 7 days, because ultimately the gut also needs to get used to the nutrition. So how to take care of the nutrition after surgery? If early oral nutrition is feasible, that is the way to go. Gradually build up over a period of time. Be extremely cautious if you are dealing with a frail elderly person. So that is important. If it cannot be achieved, if the target nutrition cannot be achieved in 7 days, we are not able to achieve even 50% of the requirements, these are the patients where we need to think about either supplementing parenteral nutrition, and there are a subset of patients who are undergoing a major GI surgery or a pancreatic surgery. Asking the surgeons or just reminding the surgeons to put in a nasojejunal tube while they are in the operating room. Probably this is something which can help us feed and try to prevent utilization of parenteral nutrition. And the story does not end over here. If we are able to meet the nutritional requirements, well and good, but even when we discharge a patient, a lot of time the whole list of medications goes through, but the nutritional assessment needs to be done not only after surgery, but even at the time of discharge in order to optimize either the enteral nutrition supplements, oral nutritional supplements, or whatever it is in order to meet the nutritional intake, because that itself will also influence the outcome, because the patient might come back 7 days later with a wound dehiscence. Probably one of the factors which would be contributing is not looking at the nutritional adequacy. So that is the reason regular reassessment is required, and before discharge, dietary counseling and supplemental EN can improve the well-being and the quality of life. Is there a role of any immune modulating nutritional formula? Very limited, because the only evidence is by using arginine, omega-3 fatty acids and nucleotides containing immunonutrition in patients undergoing major cancer surgery post-operatively. There is not much evidence regarding its utility in the preoperative state. Have a look at the nutrition. Even standard oral nutritional support should be sufficient. Now, we all know that enhanced recovery after surgery is now something which has been going on for the past 10-15 years, where there are a lot of things which are looked at, preoperative, intraoperative, and postoperative. And if you look at perioperative nutrition, there is a lot of overlap. It's important to include both because ERAS commonly focuses on the intra and the postoperative periods. But rehabilitation can get a person ready for surgery, because the process of surgical recovery should begin even before the surgeon puts a knife into the patient's body. So there are significant areas where we need to improve. So nutritional assessment, which needs to be more uniform SOPs need to be there. Post-operatively, assess the patient for enteral nutrition, identify the patient who merits supplemental PN. There are certain specific challenges in the Indian scenario. There is usually a lack of a dedicated team and absence of SOPs to audit nutritional interventions where we can do better. Perspective of caregivers. Again, the intensivist might think in a different way, a surgeon might think in a different way. To give adequate time to optimize the person for surgery. A lot of Indians are on a vegetarian diet, so there is a challenge to adequate micronutrient intake. It's important to increase the awareness of perioperative nutrition across specialties. It's important to incorporate it into the educational curriculum. And again, financial constraints. The first thing with the patients will say, my insurance is not going to cover for the feeds. So why can't we switch over to kitchen feeds? So a lot of things which need to be looked at. So if we look at perioperative nutrition to optimize therapy and convert into surgically meaningful outcomes needs to start way back from the preoperative period, go through the perioperative, postoperative, and even post-discharge. So thank you very much for your attention.
Thanks a lot, madam. We are running short of time. We'll take some 1 or 2 questions in any session, in any presentation. Anybody has some questions, please? Any comments, respected chairpersons, on the session?
In fact, a lot of comments, you'll be shocked. The AI stuff, you have been fooled massively. Most devices that they tell you have an AI there, they are fooling you. I'm professor of medicine here in pediatrics in medical college, and I'm also professor in VNIT here and teach mechanical engineering. So I can give a lot of insight. Like a device which is available here is saying that we have an AI compensation for a pulse oximeter reading. So the pulse oximeter, which shows it falls to 60%, it shows it increase the FiO2 to that level. Now this can never happen because an alveolar gas will equilibrate with peripheral gas after 20 minutes. After 20 minutes. So if you see an FiO2 of 50 and you react to that, you have gone about 25 minutes before. And there's an auto-retrogressive correction, that kind of a thing, which is not an AI. The present devices that are available in a country which would market you as an AI do not have AI. They are smart algorithms, which is a part of my apps also. So algorithms doesn't make AI. So be very careful. Presently, the generative AIs are almost missing. We don't have that kind of a data to say that I'm AI empowered. We are not. Like this was an example. This sir, pulse oximeter shows fall in FiO2, fall in saturation of FiO2 will increase. This can never ever happen, as I've told you. So AI is very much there, but there's far much of fooling about AI. So I'm a part of an AI team in IIT Bombay, and that kind of AI is yet to come. Most devices do not have it. Algorithms would have, definitely, but we don't have enough data to generate that kind of an AI. No, apart from that, we should understand what an AI is. Like where it is in. So I'm a part of DM high altitude medicine with Rishikesh. When a jet goes off for 10,000 feet above level, then the AI really starts coming in. Not at sea level as we often think. And a lot of those things do not really happen. As ABG is concerned, stop reading ABG now. AI will give you metabolic acidosis alkalosis in a second. In a second, you just have to talk that my patient 79 years has PO2 of 70. I'm at 10,000 feet above sea level. And what is it? But for example, like we got an award 6 months back in US on an Innovations 2024. There were a lot of AI devices, and ours was the only device which was based on a simple principle of engineering called water hygrometer. We got the first award on that. So people do understand that the basic physics remain. And don't get fooled by a device which says this is AI enabled. 90% is not AI enabled. They're using some algorithms and telling you that this is it. This is not the truth. So what we should know now, AI tells you triple ABG disease. Clinically, I should be able to see what electrolyte is there, what's going on in ABG, what was the history of the patient. So it is the interpretation of that report with the clinical matters is what is going to be important. Rest of it has been great foolishness going on. That is just a mechanical language that gives you some algorithms, but that is not AI. So be very, very careful. And, like we should be knowing, is it really AI? In fact, we talk more of the, we might kind of know what's the mortality given 10 variables, but are these variables for Indian physique and body, Indian surface area to body to weight ratios? All kinds of things have to be yet spoken to. And it's for last 10 years I've been working on these fields, and be very, very careful.
Thanks a lot, sir. Thanks a lot, Dr. Dev Pujari, sir, for your excellent comment.
Yes, yes, sir. Yes, sir. I was giving the AI talk, so I totally agree with you. But I see AI is it does not evolve. It is I will say that it is still evolving, but is rapidly evolving. That's what I want to convey you, sir. So even the adaptive, even the logistic regression, whatever the method, and even the adaptive support ventilation, basically they are also. Yeah, there is some kind of AI is involved in that because it's not like there is an overlap of AI and whatever that we are still using. Sir, and it is the AI also, whatever happening, it has to be, it is continually validated and updated. It is a very active process. So that's what I want to, like, fooling around, maybe some kind of AI element may be there, which will not be as accurate as what is being projected, whatever is there. But what I mean to say that it is rapidly evolving and it is rapidly getting updated, validated, and we have to see how it is going to evolve, sir.
So adaptive support ventilation
Yes, sir.
is a mechanical reflexogenic action.
Yes.
So that acts in 0.03 seconds. Now this is machine. It's not a true AI. So it will, the moment I have a trigger of 0.3 minus centimeters, my trigger will work. And what has happened is the electronics has evolved.
Yeah.
The AI component of it is still getting used in medicine. So it's just like we made India's first ventilator.
So
the
there's a
response
closed
time
loop
was like,
system. There's a closed loop system.
yeah,
Even
absolutely.
happening the adaptive support ventilation. That's also a sort of AI. Also is partly there is an overlap of AI is happening there as well.
True. So even the closed loop system truly is not AI. Like you talk to the real AI fellows.
Part of the AI is also involved. That's what.
Exactly. So they will say stop at 20 centimeters of water. Okay. Now true AI would generate that you take the height of the patient, height will calculate tidal volume, feed the disease pattern ARDS with such and such ratio. It will give 5 options. You want to have PEEP, you can say PEEP. You want to have this FiO2. Now, as the data will generate, it will don't use so much of PEEP. So that will really come. But the machines presently, like adaptive support ventilation, class example for closed loop electromechanical system. Presently, it's not truly AI enabled.
Thank you, sir. We'll request all the chairpersons to please come forward for felicitation. On behalf of Mahakritikon and SSCM Nagpur, myself, Dr. Shivam Punyani from Savner and Dr. N.K. Joshi sir from AIMS Nagpur, would like to thank all the respected chairpersons, speakers, and delegates for attending the excellent session patiently. Now we move forward for another interactive session, that is critical care quiz. Thank you.
Check. Hello. Check, check, check. Check, check. One. Check, check, check. Check. Hello. Check. Hello. Hello. Check, check. Hey, check. Check, check. Check. Hello. check, check, check. Check, 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 check. Hello, hello.
Hello everyone. We welcome you all for the critical care quiz organized by the team of Mahakritikon 2025. And to begin with, may I have the privilege to invite our judges on the dais. May I invite Dr. A.K. Sir, Ajit Kumar A.K. Sir, pulmonologist from Bangalore. Also, Venkatraman Kola Sir, the Director Critical Care Medicine from Yashoda Hospital, Hyderabad. Thank you, sir. Yes. To begin with, we will have the introduction of our teams. All of them have already passed the preliminary round, which was with the 13 teams, and now they have entered into this final A, which we have 6 teams from the all over colleges from Maharashtra. Over to team A.
Good afternoon. I am Dr. Shadab Badar from NKP Salve Institute of Medical Sciences. This is Dr. Prajakta and Dr. Mehek beside me. Anesthesia.
Good afternoon, everyone. This is Dr. Pranayak Panikar from GMC Nagpur. We're medicine residents with teammates Dr. Vaidehi and Dr. Tanvi.
Good afternoon. I'm Dr. Camelia Chaudhary, and I'm from NKP Salve Institute of Medical Sciences. And this is Dr. Sanskriti Boob, and this is Dr. Shivam Bhattar.
Good afternoon. My name is Dr. Ayush Sikchi. This is my teammate Dr. Rajesh Band and Dr. Tapesh Jain. We are from GMC Nagpur Medicine Department.
Good afternoon. I am Dr. Santosha and my team members are Pranali and Iltakap. We are from IGMC Anesthesia.
Good afternoon. My name is Dr. Prabodh Sardar, Department of General Medicine, IGMC Nagpur. He's Dr. Chaitanya Ghule and she is Dr. Anushka Joshi.
We welcome you all for this critical care quiz. Now we will be having a 6 rounds, and to hand over the proceedings of first round, I will hand over to my colleague Dr. Harish.
Welcome you all. So as we have already conducted a preliminary round, you all know the rules. Still, the first utter answer which is heard by judges and quiz master will be final. So if 2-3 answers are given by simultaneously by a team member, the first one will be considered as the right answer which has been put up by the team. So that will be decided by the judges and quiz master, whatever. So this is we have 6 rounds, and we will update you the rules of each round before starting the round. Okay. So we'll begin the round 1. So round 1, each questions carry 10 points. That is non-transferable to other teams. The question goes to audience if it's wrong and wrongly answered. There is no negative points. Each team will get 2 questions. After completion of first part of the round 1, we will start second part again from the team A. Okay. So first question for team A. In 40 seconds you will get. In pressure control ventilation, which parameter most directly determines tidal volume?
Compliance.
It's wrong. Anyone from the audience? It's inspiratory pressure above PEEP. Okay. PI. Driving. So, Team B, question. Next question. Name any one condition where pulse pressure variation becomes unreliable for hemodynamic monitoring. Timer.
Any condition with autonomic instability like diabetes also.
Diabetes, we are talking about pulse pressure variation. Hemodynamics it is. Sorry, you have attempted it, so it's a wrong answer. Anybody from the audience? No, not to the senior intensivist. The students we are giving the prizes. Anybody from the students, please? May I know your name, ma'am? Please stand up.
That answer has already been prompted. There is a reason for why it is.
Meanwhile, I request Suresh Ramasubban sir to please take over the seat as a judge, sir.
So next question for Team C. What is the mechanism for defect responsible for propofol infusion syndrome?
Timer. Hello. Prostaglandin release.
Wrong. Anyone from audience?
Anyone from audience can answer the question and you'll get the exciting prizes. Just raise your hand. If you'll prompt, you won't get any gift. Yeah, please. Wrong answer.
Defect mechanism or defect of for propofol infusion syndrome?
Huh?
No.
No.
The team members.
Fatty acid oxidation.
Yes.
So that is
It's
the right
a
answer.
mitochondrial fatty acid oxidation defect. So team. No, already. No marks. So next question for Team D. In severe metabolic acidosis, compensatory hyperventilation lowers PaCO2. What is the name of formula to calculate expected PaCO2?
Winter's for
Yes. Yes, correct. So if you have listened to previous lectures, you will have. So next for Team E. The most common cause of post-operative pulmonary complications is.
Please attempt. There is no negative marking. Please attempt.
Pain.
It's a pulmonary complication.
Pulmonary complication. Audience. Cause of complication.
Type 3 respiratory failure. Type 3 respiratory failure.
Yes, answer correct. We get secondary pneumonias basically. It's atelectasis. Was for getting secondary pneumonia.
So, word, term.
The terminology, the question should have been framed.
Can we get one more question? We see the point is the specification of that most common cause of post-operative, probably the manifestation of a post-operative patient, as I was mentioning. So we will give in the view of a English confusion, we'll give one more chance to.
So team E gets next questions. They get one more question. So team E, target ICP for traumatic brain injury patient is less than.
Less than 20 mm.
Yes. Correct.
That's the right answer.
Team F, the Vexus score in ICU is used to evaluate. This has been talked in conference since last 2 days and 3 days because of workshop also.
Shop, which was free to you. We have given you the free workshop to make you prepare for the quiz. Last 5 seconds, at least attempt. Oh. From the audience, please. Not Rahul.
Fluid responsiveness or need of inotropic support in a shock patient.
Sorry, fluid.
Fluid responsiveness or need of inotropic support in shock patients.
Any more precise answer.
Venous congestion.
Yes. So systemic venous congestion.
So,
So we will move to second part. So this is image based. So this will be image. A image will be displayed, and after displaying the image and completing my question, your time will start.
So this is the second round.
This is part of first round only. Second part of first round.
Okay. So you want to tell the score now?
No, sir. After the first round
Yeah.
completed. So you will get one image. You have to identify. There will be some questions on the image only. You have to.
it is also non-transferable.
Non-transferable.
No negative
No
markings.
negative markings. Non-transferable. Okay. So there might be some arrow or pointer where you have to concentrate on that image. Okay. So first question to team A. A 75-year-old man with history of COPD presents with fever and increased sputum production, and ECG is taken in emergency department. What does it show? Concentrate, focus on the arrows. Or
5 second, team A. At least attempt. Anybody from the audience?
Yes.
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 When you have prompted it, you are supposed to raise the hand.
Raise the hand.
I have chocolates. Who will raise hand and answer?
It's polymorphic atrial tachycardia.
Yeah.
So
Raise your hand other than.
team B, next question for you. A 18-year female presents with sudden onset right-sided pleuritic chest pain with mild tachypnea. Her chest X-ray is below. What is the diagnosis? Time starts. Correct?
Yes, that is the correct answer.
Team C. A 30-year-old female with history of Conn syndrome, secondary to bilateral adrenal adenomas, present with generalized weakness and muscle pains. Her ECG was done in ER, which was below. What is the diagnosis for ECG finding?
Put on the timer.
Hypokalemia.
Yes. Right. So severe hypokalemia. You get T and U waves. Team D. A 60-year male with cirrhosis of liver was sedated and ventilated in ICU due to hypertensive intracranial bleed along with slightly deranged INR. His urine color was as below. What drug he is receiving for sedation?
अरे टाइमर तो खत्म होने दो. Please, no prompting. Propofol.
Yes.
Right answer.
Right. Propofol and cirrhosis of liver, you can get greenish color urine. Next question for team E. A 40-year-old man had been in ICU for nearly 2 weeks and was slow to wean off from ventilator due to ARDS. A percutaneous tracheostomy was performed. Following the procedure, he developed requirement for increased respiratory support. He was sufficiently stable for a CT chest to be performed. Representative images are shown below. What is the diagnosis and possible cause? Timer.
Ten seconds. There is a clue in the question. Last 5 seconds.
Acute emphysema.
More precise, yeah. Anybody from the audience?
Audience. Yes.
Huh.
Pneumomediastinum.
Yes, that's the correct.
Please introduce yourself. Dr. Pranav Baghora, critical care student.
It is a pneumomediastinum.
One chocolate.
And the possible cause are complication of tracheostomy resulting in small tracheal tear. So next question for team F. A previously well 50-year-old presents with sharp severe chest pain after a long haul flight from North America. A chest X-ray and ECG was performed and revealed no abnormalities. The examination is unremarkable. CT chest was done, suggestive of.
Aortic dissection.
Correct. So now we had completed our round 1. Next question is for audience. A 57-year-old man who arrested on ward post-operatively. The initial rhythm was ventricular fibrillation. Following defibrillation, 2 minutes of CPR, he had idioventricular rhythm with a rate of 40 but remained pulseless. CPR was continued for further 2 minutes. The patient then had return of spontaneous circulation and was intubated as he remained unconscious. This is his post-intubation ECG. What does it shows?
Pin drop silence from audience.
Please raise your hands. Dr. Rupesh want to attempt. Pulses alternance.
No, not pulses alternate.
Patient,
gift for
I will give one hint. Patient was on Cardaron. Amiodarone. He was on tablet Amiodarone. Okay.
Audience का?
The ROT phenomenon predisposing to torsades.
Yes. RRT.
Dr. Kritika Singh, medicine
Here
student.
is the underlying sinus rhythm with normal axis QRS complexes are high voltage and there was R on T phenomena. Next, one more question for audience. A 65-year-old male presenting with right-sided flank pain radiating to groin, diagnosed as renal colic. The following CT scan was taken. What are CT findings? It is a plain CT radiograph. There are two findings.
Audience. Yes.
No.
Kidneys.
Necrotizing pancreatitis.
No, no. Wrongly diagnosed as renal colic.
Time up.
It's
Anybody?
quite visible.
Yes.
Aortic
yes,
yes.
It's right-sided retroperitoneal blood and abdominal aortic aneurysm. Okay.
No chocolate.
So we
What was
conclude
out?
our round one.
So at the end of the round one, the scores of the team are AV team to please display the score, please. Team A, sorry, with no marks now. Team B, 10 marks. Team C, 10 marks. Team D with 20 marks. Team E, 10 marks. And Team F, 10 marks.
Round 2.
Next, we progress to round 2, which will be taken care by Dr. Sanket Agrawal.
Audio visual team, can you show?
Please put on the PPT.
Good afternoon, everyone. So our second round is quiz round is case-based scenario. Each team will be shown only one question. The question carries 20 marks. There are no negative markings. There will be 4 options will be given from which you have to select the best. Along in the question only, we have highlighted the points which you can read and get the best answer. Okay, starting with team A. So a 40-year-old woman complains of unabated thirst that begins 3 weeks ago. She is constantly drinking and goes to the bathroom approximately 6 times per night. She has lost 6 pounds over the last week and has started on lithium for bipolar disorder. She is hemodynamically stable with a sodium of 149 and urine osmolality of 120 milliosmol per kg. So what is the likely diagnosis? Diuretic induced dehydration, central diabetes insipidus, nephrogenic diabetes insipidus, or none of the above.
Timer, please. Team A, you have to attempt this. You haven't been attempting the question. At least make an attempt.
The clues are given in the question.
Last 10 seconds, please put.
Nephrogenic diabetes
correct.
insipidus.
That's the correct answer. You
Correct.
get plus 20 for that.
So lithium, it is known to cause the nephrogenic diabetes insipidus by inhibiting the tubules to insert aquaporins. Okay. Team B, next question. A 52-year-old man who was admitted to the inpatient unit with the complaint of fever, wheezing, cough with sputum production. He does not have any relevant past medical history, no recent antibiotic use or previous hospitalization. A X-ray test has been performed and demonstrate the presence of bilateral infiltrates. Since the patient reports a childhood penicillin allergy, which is anaphylactic reaction, the medical resident decides to use a fluoroquinolone antibiotic for this patient. So which fluoroquinolone is not recommended for this indication due to a higher likelihood of resistance? The options are moxifloxacin, Leoflox, Gem, and Cipro. Timer.
Last 15 seconds. Team B.
So the question has asked which is not recommended.
Not recommended antibiotic in.
Not recommended. Yeah.
Yes.
Yeah, please, anyone in the audience?
Anyone?
Ciprofloxacin.
Yeah, correct answer.
Can you introduce yourself? Dr. Shantanu Ambulkar, IGMC medicine resident.
So according to the guideline, Moxi, Levo and Gem are recommended, but Cipro has least penetration. So for team C, so you have admitted a 55-year-old man with a history of liver cirrhosis to ICU. The patient has been diagnosed with pneumonia. There are no risk factors for hospital-acquired pathogens. Patient is in shock, currently on vasopressors. The lactate measurement was 5.4 initially. You initiate antibiotics, suspecting it to be community acquired, start aggressive fluid resuscitation based on his weight of 70 kgs. 5 hours later, he is hemodynamically improved and making adequate amount of urine. You remeasure the lactate and find that it has not decreased. So what is your next best step in this patient? Obtaining a CT of the chest with abdomen pelvis to ensure adequate source control, continuing with aggressive fluid resuscitation for the next 4 hours and repeating a lactate levels, considering alternative reasons why the lactate may not have decreased, or broaden the antibiotic to cover healthcare associated pneumonia.
Team C. Last 15 seconds. Make an attempt. Make an
We'll go
attempt.
for A, obtain a CT of chest and abdomen.
That's a wrong answer.
Anybody from?
Not eligible.
Yes, C is the correct answer.
Sir, explanation please.
So this patient, as you can see, he is having a liver which is cirrhotic, on the top of which he has developed pneumonia. So cirrhotic patients.
I think more important thing is the fact that the patient is getting better. So once the patient is getting better, whatever tests you need to be aware of what is the other false positive, why is it not decreasing. So whether it is liver disease, whether he got whatever is the cause of other causes of lactic acidosis, it's okay. Whether it's a norepinephrine, sympathetic overdrive, so many causes. So the answer is consider alternative reasons. CLD may or may not be one of the reasons, but yes, but he has highlighted it in black, so maybe that is the reason in this.
So that's why after adequate resuscitation, there is no role of lactate, looking at the lactate, monitoring the lactate.
Okay. Next question to team D. So a 30-year-old man decided to go hiking. After 48 hours, he has reached an altitude of 4,000 feet. He decided to continue further hiking when he suddenly complains of headache, breathlessness. Then he started to develop fever, chills and begin coughing up pinkish frothy secretions. He starts to climb down where he encountered other hikers who managed to help him. So what is the primary treatment in this patient? Options are descent and oxygen supplementation, nifedipine, sildenafil or
This question is taken from Kaplan's review of productivity.
Descent and oxygen supplementation.
Correct, correct
Yes,
answer.
that's a correct answer.
Nice. So high altitude pulmonary edema, you must be knowing that the primary treatment is descent. Other options, nifedipine and dexamethasone also can be given. Next, team E. So a 69-year-old man with a history of prior strokes and atrial fibrillation who was on warfarin presents with sudden onset lethargy and left hemiplegia. The non-contrast head CT reveals a large intraparenchymal hemorrhage. So what is the next best step in this patient? Administering mannitol, obtaining a CT angiography, placing an EVD for hydrocephalus, or administering prothrombin complex concentrate.
Team E, make an attempt.
Please
Last
make an
15 seconds, please.
Read the question.
Yes, answer it.
We have a
5 seconds.
Option D, prothrombin complex administration.
correct answer. So the reversal of existing coagulopathy with this PCC or vitamin K is the primary step in the managing. Other options like administering mannitol if there are impending signs of herniation, EVD, CT angiogram. So next team, a 27-year-old woman with no significant past medical history went hiking at a nearby park. 48 hours later, she found an adult tick that was still attached to her skin. Lyme's disease. In that area, the rate of infection was around 20%. There were no allergies to medication. So what is the next step in this patient? Giving doxy 200 BD, 200 per orally on day 1, ceftriaxone 2 gram IV for 14 days, rifampin 300 mg twice daily for 7 to 10 days as an alternative, or atovaquone 750 mg per orally 12 hours plus azithromycin.
Team F,
You can attempt.
make an attempt.
Option A.
Correct answer.
Correct
Doctor.
answer.
So for prophylaxis 200 mg is the dose. Other options like ceftriaxone 2 gram IV is the dose for treating in patient who had developed early neurological manifestations, carditis also. Atovaquone with azithro is the treatment for babesiosis. Thank you. This is for audience. A 50-year-old man with a history of thalassemia was involved in a motor vehicle accident. He was found to have hypovolemic shock and required massive transfusion. There was concern for iron overload. The labs are hemoglobin of 10, ferritin of 500, transferrin, AST, ALT of 10 and 12, total bilirubin of 8. So what would be the next step? So options are do nothing, perform phlebotomy, administer deferoxamine and deferriprone.
Administer deferoxamine. Option C.
Not correct. So this patient history is
Perform phlebotomy.
on phlebotomy with a normal hemoglobin, 10 hemoglobin thalassemia patient who is most likely to undergo iron overload.
Do you want to decrease the percentage saturation? T-sats are very high. Isn't very high.
Time up for audience.
So the answer is do nothing.
So we have come to the conclusion of round two. So after round two, we have a scorecard ready. Team A got 20 marks. Team B 10 marks. Team C 10 marks. Team D 40 marks. Team E 30 marks. And Team F 30 marks. Yes.
So for round three, we would like to invite Dr. Rashmi Agrawal ma'am.
Actually, I'm upset. My lot of audience are leaving, and this round is basically for the audience. It is a video round which everybody will be going to enjoy. So, can we pull on some audience for the round, please?
Round three.
Yeah, so my PPT, because it has lot of video, it will take some time to upload. So going into the details of this round, this is a video round. We have embedded the Bollywood theme into this round. As you all know, ICU is a little tense atmosphere, but we all always are not tense. Lot of years into critical practice, we become little cool, we sing along. So this singing song will clue to the diseases or pathology or the procedure happening into the ICU. You will get a video which you have to identify or link to the procedure which is happening into the ICU. I will provide you with the some clues obviously. Since one video can have multiple diagnoses in the participants, also in the audience, so the judges answer will be final. If they accept it to be a concluding, we will conclude with that answer, and after the video identification you will be getting a question. So in this question, after listening to the question, you can opt for double or not double. So if you opt for double, you will get plus 20, similar negative markings if it is wrong. If no double, then plus 10 and similar negative marking if it's wrong. Little complicated, but we will make it easier. Identification plus 10 marks. If you don't identify also, there is no negative markings. So any participants have any doubts? They want to ask something if they have not understood anything? Yes, it's uploading. It will take some time, sir.
Where is Dr. Afzal? You can ask few questions. He has already got few questions.
Which famous Ajit dialogue is most applicable to Indian critical care? All heard of Ajit? Famous. Mona Sona. Mona Sona. Oh, okay. So
तो ये आ रहा क्यों
generation
नहीं
gap.
था?
Sorry.
पता क्यों नहीं? Yes.
So let's start with the video round.
ICU के सुर, melodies of medicine. So I have already explained you the rules of the video round. We'll start with team A. The moment I will move to the slide, you will get a song.
Sound, please.
Sound, please. If both of them are breathing together,
Start the timer.
I want to ask them what is the next if the patient and ventilator breathing together?
Synchronized intermittent mechanical ventilation.
That is already happening. I'm asking about what is the next thing which we'll do. And what is that if both are breathing together? What is
Next mode.
next mode which we put? Pressure support.
Yeah. We can give it.
Yeah,
Pressure support.
My answer was spontaneous breathing trial, or we will give it for pressure support also. So now we move forward to question. After question, you can attempt whether single or double. Okay.
Single and double, please explain.
After question, you can opt whether single or double equal negative markings. Okay. So the question is, 46-year-old man presented with fecal peritonitis 2 weeks ago. He is now receiving TPN because of generalized ileus. There is mild generalized weakness. He is afebrile. Current ventilator settings are CPAP of 5 and pressure support of 12 and FiO2 of 0.25. ABG shown, so pH of 7.42, EtCO2 of 38, PO2 of 92, bicarb of 24. Why this patient is difficult to wean? So patient is on pressure control ventilation with an ABG. Timer, please.
If you are not answering, then there is 0 mark only. Single or double, you have opted or not?
Last 9 seconds, at least. Achha, there is a negative markings, yes.
So time over. So anyone want to take the question? Yes, please.
He is getting all the prizes.
Prize is only for audience round.
Just a guess actually. Respiratory muscle weakness because of hypokalemia secondary to TPN, not giving adequate potassium probably.
Then why would you put all the EtCO2? Potassium के लिए EtCO2 कहाँ से आया?
I will pass.
Very smart.
Because of negative marking, you are not getting prizes.
But we will clap for you for at least trying in every round.
Anyone who want to attempt?
Patient is on TPN
Even
with
organizing committee.
unmonitored. So going forward is an overfeeding syndrome. You can see the high volume he was taking and the RR which was there. So high minute ventilation. Team B, are you ready? So music louder please. This is what every doctor want in every ICU. That nothing will, you just want every heart to beat. And if it doesn't beat, then what do you do? It is you. If it doesn't work, what we will do? Yes. So the clue was it dil dhadakne do. You want every heart to beat. If doesn't, you go for a cardiac arrest or it is CPR initiation. Ideally, the answer should be cardiac arrest. Next is the question. A 16-year-old woman is admitted with diazepam and paracetamol overdose. She requires airway protection because of depressed consciousness level. She is intubated uneventfully with grade 1 laryngoscopy. Pulse oximetry shows saturation of 100% with a good waveform. Comment on CO2 waveform.
Single or double? Double.
Yes, that's the right answer.
20 marks.
Moving forward, Team C. This is a critically ill patient in the ICU, showing signs of recovery after long stay. A patient who has recovered from the critical illness and now he is asking for Shakti. Enteral feeding? No, it is not. Clue is for the disease or the recovery part. Yes, it is for diagnosis. Our audience friend is already with hands up.
Is it critical care neuropathy?
Yes, that's the correct answer. So now coming forward is your question. This is a graph showing EtCO2 waveform, CVP waveform and arterial pressure waveform. It is of a 23-year-old woman had a subarachnoid hemorrhage 2 days ago. You are called to see her urgently because of sudden profound hypotension. What is the most likely cause of hypotension? Yes, they have to attempt. Last 15 seconds.
Single.
Single, yes.
Raised ICP causing
No,
radiation.
wrong answer. Anybody from the audience, please? -10 they will get, huh?
Pulmonary embolism.
Yes, it is air embolism, but pulmonary embolism also we give. You can see in the graph that EtCO2 is going down, pressure is going down, but CVP is rising up. So RV pressure is going up. A critically ill patient in the ICU who had sustained something.
Return of spontaneous circulation.
Yes, correct. Post a cardiac arrest, life just hit afresh. So this is your question. What is 20, 30, 40 target during cardiopulmonary resuscitation? What does 20, 30, 40 stands for?
Last 14 seconds.
You're not attempting it. Okay, anybody from the audience?
ACLS training. Anyone?
OMG, nobody?
High quality CPR.
NABH.
So answer is 20 is EtCO2, 30 is coronary perfusion pressure and 40 is diastolic pressure. These three targets is the high quality CPR indicators. Next to team E. Are you ready? Yeah. Your ICU patient. We face lot of these patients regularly.
ICU psychosis, agitated patient.
Yes. In terms of ICU, what you will call them, what condition you call them? You will give you the marks, but just the condition. Yes, ICU delirium it is.
We don't want you to use the word ICU psychosis.
Because
delirium is a medical condition unless proven otherwise. Psychosis means you're not responsible. So you're shirking away your response. So we don't want you to use
Okay, so moving forward, question. A patient in your ICU whose low flow alarm has begun to sound repeatedly or last half an hour has taken the flow volume loop on the ventilator display. What you will request to the patient nurse after seeing this flow volume loop?
Suctioning of the tube.
Yes, that's the correct answer.
Single, double, now you
Single,
only.
we will give you single only. Team F. Shit, I have one more question for you. I have just missed on the. Anybody from the audience, please? Yes, ma'am, you please. Yes, so I'm asking.
End of life.
अरे कितने देर तो बचा अच्छा
Time why नहीं होगा?
अच्छा ठीक है end of life care is not the answer, you get the chance to answer. Start the timer please.
Please reset the timer. Yes.
Recovery.
अरे जिंदगी दो पल की which recovery बेटा? Attempted, yes. So it is a septic shock multi-organ dysfunction patient who is demanding जिंदगी दो पल की. So what type of machine modality required in a septic patient with ARDS? This machine modality which is required in septic patient with ARDS, and you have to list any two complications. Single or double?
Single.
Hmm.
Venovenous ECMO.
Yeah, but I'm asking septic patient with ARDS.
Complications you are asking now?
What type of this machine modality is required in septic patient with, your answer is VV ECMO.
ECMO.
So that's a wrong answer. It is for ARDS. I'm saying septic patient with ARDS, which anybody from the audience?
So VA ECMO.
With septic shock.
VA ECMO.
No.
And the question is, she's not asking what kind of ECMO you will initiate. In that patient, you need this machine. What are the two indications required? Is that the question?
No.
Severe in a septic patient?
I am saying a septic.
I'm assuming the patient is hypoxic and hypotensive also.
Yes, that is the question. So what?
So VA ECMO will be the best modality if he's having refractory shock and refractory hypoxia.
ECMO is also a good answer. But
Answer me. क्या हुआ? You have any questions?
I said VV ECMO in refractory. Yeah.
VV ECMO is wrong answer.
VV ECMO is a wrong answer. Either VA ECMO or a hybrid ECMO.
See, I think maybe we will keep that points on there, but this is an area of gray zone where we only use VA ECMO if there is a cardiac component in a septic shock patient. If it is exclusively a distributive shock, most of the times in a septic shock patient, probably we will not attempt. But if I have to attempt, I need to attempt a VA ECMO, not VV.
No, the VA ECMO also you have a septic cardiomyopathy. Septic. Otherwise, and if you use in these kind of patients, if you put patient on ECMO, it is going to worsen. Shock is going to worsen. System inflammatory response syndrome is there.
My answer was a hybrid ECMO, but if the judges agree,
No.
we can give them for VV ECMO.
Highly debate for it.
No, not for VV ECMO. Judges is saying not for VV ECMO. VA ECMO we can give. We can have any other question also.
So VA ECMO will be used only in sepsis when you have a septic cardiomyopathy, that is giving rise to hypot shock. Septic shock means every patient on the earth would have been on VV ECMO, the way VA ECMO, if the septic shock is indicated for VA ECMO. I think we should change the question.
You will get full new question now. Full new question.
मस्तानी मदहोश किए जा मुझे जो आई खींचे तेरी ओर लिए जा ये शाम मस्तानी मदहोश किए जा मुझे जो आई खींचे तेरी ओर लिए जा
Timer, please.
ICU patient. Under.
ICU sedation.
Yes, it is ICU sedation. Your question, okay? Propofol infusion syndrome is not strongly associated with most strongly associated with use of propofol less than 20 mics per kg per minute, co-administration of opioids, catecholamine or steroid use, low dose infusion in renal failure. Most strongly associated with.
Single. Option D.
Option D. Which option?
Option D.
Yeah, that's a wrong answer. It is catecholamine or steroid use, which is. Okay, so I had questions for the audience, but unfortunately that have all been used up. But nothing or the less, this song is dedicated to all intensivists sitting in the audience. As we routinely do in the ICU. यहाँ के हम सिकंदर. Clap to all the intensivists sitting around here.
क्लोज्ड आईसीयू में फिट होता है.
Even if it is open ICU, this is for intensivists who fights around the primary consultants to win the race. We come to the end of round 3. Thank you.
Scores at the end of round 3. Team A 30 points. Team B 40 points. Team C 10 points. Team D 50 points. Team E 50 points. Team F 30 points.
So the next round is abbreviation based round. So Dr. Piyush will be conducting it. Please put on the PPT round 4.
So our next round is less is more. So I will tell the rules. The round will be played in a clockwise manner. So each team will get 2 questions. But first of all, there will be one question to every team. We will first finish that till team F, and we will rotate the questions once again. And each team will be given an abbreviation which they have to decipher. If the teams get it right in first go, anyways they will get 10 marks, and the teams will get 15 seconds to answer. And this round is non-transferable, no negative marking, and it will be open for audience to answer after the times get out. So for team A, this is the question. So you have to tell about E fast, and we will be providing a clue that it is regarding to critical care imaging. So you will get 15 seconds for this to answer.
Extended focus assessment sonography in trauma.
Yes, correct.
Yes, correct answer.
Very good. So to get the marks, you will have to tell the full form of that abbreviation in a correct order, and completely the answer should be correct. So for team B, the next question is CIRCI, and the hint will be it is related to the endocrine system of in critical care medicine.
No negative markings.
Yes. You can attempt.
Time over. Anybody from the audience? You can attempt it.
Steroid insufficiency.
Yes, correct. So I request all the teams to at least make an attempt, as there are no negative marks and it is a scoring round. So coming to team C. What is FVNA? And it is related to renal critical care.
C.
Fraction of excreted sodium.
Yes.
Fractional excretion of sodium. Yes.
Correct. So the next question goes to team D. What do you mean by XDR? And it is related to antibiotic resistance pattern.
Team D.
8 seconds remaining. 7.
Attempt.
6.
Yes.
No. It is not extended. It is extensively drug resistant. So we will not give you marks. Okay. So next question to team E. Team E ready? What is EVLW? And it is one of the important indicators of fluid status. You have 12 seconds to answer.
Extravascular lung water.
Yes, correct. Very good. Yes. Okay, team F ready? Okay. What do you mean by Q so far? The hint is given there. So your time starts now, please.
Quantitative sequential organ failure assessment.
Sequential organ failure, sir.
Tell me completely.
Sequential organ failure assessment. Quick sequential organ failure assessment.
Okay,
That's the correct answer.
Correct. So we will. The next question goes
We
to
have completed one circle.
Yes.
One
So there
circle.
will be another circle.
This will be
Another circle. So there will be one question to each team, and you have still time to attempt. So the next question for team A, what do you mean by SLED? And the hint is it is a mode of RRT.
Sustainable low efficiency dialysis.
Come up with the first word again.
Sustained low efficient.
Yes, that's correct.
Okay. So the next question goes to team B. What do you mean by CAM ICU? It is a bedside tool to assist delirium in ICU. It is one of the score to assess the delirium in ICU.
Last 2 second, team
2
B.
second, 1 second. See,
Come
Take
up
1
one
second.
second. 1 second.
Confusion assessment, monitoring analysis.
Wrong answer. Anybody? Any of the team, other teams?
It's method. Yeah. For
delirium.
Yes.
Yes. So the next question is for team C. Team C, ready? What do you mean by IABP? It is related to CVS.
Aortic balloon pump.
Yes, correct. Good. Next question is for team D. APACHE, Apache 2 score. It is used to assess the severity of, to predict the patient outcome in ICU.
Apache, you must have heard. Nobody find out the full form any point of time.
But it is used most commonly. Last 1 second. Okay.
Anyone?
Anyone from audience or
It
team?
was a hint. It was a hint for the answer also. इतना full form के लिए. Teams.
From public, someone wants to attempt.
For alert audience.
Acute physiology and chronic health examination, I think.
Yes.
It's evaluation.
Yes, correct. Correct.
Partially correct.
Huh? So the next question is for team E. What do you mean by SCVO2? It is related to hemodynamic monitoring in ICU.
Central venous oxygen saturation.
Yes, correct.
Yes, that's the
Very
correct
good.
answer.
Yes, good. Next question is for team F. Team F, ready? So what do you mean by VILI? It is related to ventilator and dash. अभी सभी बता रहा है.
Ventilator induced lung injury.
Yes, very good.
That's the correct
Good. Audience के लिए बोल सकते. So few questions for audience. This is very easy. What do you mean by HRT?
Heparin induced thrombocytopenia.
Yes, correct.
Correct answer.
What do you mean by LVAD?
Left ventricular assist.
Now this question is chocolate and आपके पास? हाँ.
No chocolate.
हाँ.
Pen drive.
Last question. Yes. What do you mean by MARS? Mars.
It's not a planet.
हाँ. This is done on Earth. चलो it is related to rescue therapy in acute liver failure.
So what is that?
हाँ, partly correct है. It is molecular adsorption resurfaction system.
चलो, over.
Okay, thank you.
So, Dr. Rashmi will declare the marks
Yeah.
in round 4.
Team
Meanwhile,
A, Team A is 50 points. Team B at 40 points. Team C at 30 points. Team D at 50 points. Team F is leading the total with 70 points. Team E and Team F at 50 points.
so let me brief about the next round. It will be a very interesting round. I'll be giving some clues. So you'll be able to see the clues on the PPT, and then you have to guess the either modality or treatment, and you have to answer the question. So I'll put on the sample questions. First of all, the rules. This is the clue round. No prompting from anyone will be entertained. Each correct answer will get 10 marks, but the wrong answer will be minus 10. Each team will get roughly 40 seconds. So we'll give you 40 seconds. 40 seconds. Sample question. This modality was used in the famous ladies' ailment. What is it? Anyone can loudly answer it. ECMO. Very right.
Sir, there is one round, one cycle only for this round.
2 cycles.
2 cycles.
2 cycles.
And if they don't answer,
If you are passing, 0 marks. If you are not answering, 0 marks. If you are answering right, 10 marks. Answer wrong, minus 10. Clear? So,
non-transferable.
please start the timer. So, treatment of choice for this condition. Team A. First, identify the condition and then tell me the treatment of choice. Audience will also get prize if they answer.
Magnesium sulfate.
Magnesium sulfate.
Yeah, it's the right answer. Treatment of condition of the eclampsia is magnesium sulfate. Yeah, clap. So, team B is ready. Start the timer. What is the name of this modality? It is used for monitoring. Which is this monitor? Please don't prompt from the audience, I request.
So it is transcranial Doppler.
Yeah, it's the right answer. Please clap. So please reset the timer.
I request audience to please motivate our participant. Please clap.
So the next question for team C. So come on. Name this treatment modality. This is specifically used in COPD patients. No prompting from audience. Everyone is just telling the answer to.
No prompting, please.
Even I can hear from there. Yeah, please. No, it's a wrong answer.
Wrong.
No fresh attempt. So minus 10. It is? Anyone? ECOR, extracorporeal CO2 removal. So please reset the timer. So team D is ready. So let's hit. Give complete name of this monitoring modality. There are very good gifts for audience. Just think and answer. Just raise your hand, then we'll give you gift. Don't just prompt it. Who will be prompting won't be gifted.
20 seconds.
Yeah. Huh? No, it's not this.
Negative.
It's transferred to audience now.
Yeah, audience, please.
Anyone from audience? Neuromuscular monitoring.
No.
Minus 10.
Yeah. So
Anyone? नीचे रखो.
Oximetry, NIRS.
This is the principal use for cerebral oximetry. It is near infrared spectroscopy. So team D is done. Team E, get ready. Please reset the timer. So name the treatment of choice for this condition. Look properly. Team E. Those who are discussing that, they listen. "15 seconds. There is negative marking also.
I request everyone to please occupy the seats. Lot of seats are vacant.
Factor it.
All the people
Factor
standing over there,
Yes.
please occupy the
Factor it.
seats.
Huh?
Factor 8.
Factor 8 deficiency. No. Anyone from the audience?
Audience?
It's a treatment. I am asking the treatment of choice for this condition.
Plasmapheresis.
Sir gets
Name of the condition? TTP.
TTP. Yes, please give the gift to sir.
TTP.
Yay. Huh? Yes, yes. So, next question goes to team F. So please reset the timer. Start it. What's the name of principle of this equipment? Very easy question. Yeah, please, please. You told it.
Beer-Lambert law.
Yeah, it's the right answer. So again, we'll make one more circle. So team A, get ready. Start the timer. What was the? No, this is for audience. Sorry. This is for audience.
Isaac Esman?
Yeah. What was the medical condition that they both suffered from that can lead to a life-threatening complication? Does anyone know? Nirmal sir, please.
Nirmal sir.
Sir, almost near. Because of why? Because of what? They had what that leads to pulmonary embolism.
Deep-vein thrombosis.
Yes, sir. Right answer. Sir, please.
Thank you.
Thank you, sir. Thank you. Round of applause for Nirmal sir. Please, audience, please participate. So, team A, now concentrate. Please reset the timer. So, identify the pathology. Especially seen in after antibiotic use in ICU. "15 seconds left. There is negative marking also. Done. So anyone from audience? There are so many hands coming up.
Not qualified.
Pseudomembranous enterocolitis.
Yeah, right answer. So next question is for team B. So please start the timer. This famous celebrity had this condition, now landed in ICU. What is the diagnosis?
Very common.
You can see the third figure that it has to be proper answer, not just condition. Please don't prompt from the audience. How, sir? Sir, lip reading.
He landed in ICU.
Yeah, right answer. So next question will be for team C. Please start the timer. Identify the personality. He is the pioneer of major practice in intensive care, which till date is the only proven means of prevention of infection.
"15 seconds.
So pass. The question goes to audience. So Swapna ma'am is very eager to answer and she has raised the answer hand first. So please ma'am.
Ignace Semmelweis.
Yeah, absolutely right answer. So the next question goes for team team D. So please reset the timer. What is the diagnosis? Very common condition, especially in ICU.
Disseminated intravascular coagulation.
Yeah, right answer. So team E. What is the name of this neurological condition? I have given the figure of famous personality who had this disease. Second left. Answer is in the question itself.
When you watch that series Big Bang Theory.
Any answer? No. The question goes to audience. Motor neuron disease. Yes. Thank you.
Everyone answered.
So next question goes to team F. So get ready. Please start the timer. Which is this deadly poison? Audience is already raising the hand.
Seconds.
Paroquet.
Yeah, it's the right answer. Clap for team F. One more question for audience, I think. For audience, which poison is it? You can say it loudly. OP poisoning. Yes, right answer. So here we conclude the round 5. I'll ask Rashmi to announce the score. And after this, we'll be having last round. That will be a rapid fire round. So Dr. Shailesh will be conducting rapid fire round. He'll explain you all the rules. So welcome, Dr. Shailesh.
Five rounds हो गए ना? So we have last rapid fire is remaining. At the end of 5 rounds, the scores are: Team F is leading with 70 points. We have 3 teams at number 2 position. That is Team A with 60 points, Team D with 60 points, and Team E with 60 points. After that, Team D 50 points, and Team C can always buck up in the rapid fire with 20 points.
Good afternoon, everyone. This will be the rapid fire round. Each set of the questions will have 10 questions, and the total time for attempting 10 questions is 90 seconds. It's a time limited scenario, so try to cover maximum questions. If time permits, you can revisit the questions, but you cannot change the answers which are for true or false. And no prompting, please. Each question is of 10 marks, no negative marking. Passing can be done for the next question to cover maximum questions.
So we set the time to 90 seconds. Okay.
Excuse me, sir.
AV
Timer to 90 seconds.
90 seconds.
Sir? Excuse me, sir. Does that mean that the non-true false answers, if we give the wrong answer, we can give the correct answer later on?
No. For true or false, you cannot attempt. Change the question.
Other questions other than true and false. If we
Other
give-
than true and false, you can attempt. True, false. You cannot re-attempt true or false. Rest of the questions you can re-attempt. Okay. Any confusions?
Sir, if we attempt a question wrongly, the next time we can answer the same question again. Even if we have not passed it, we have attempted it. We can re-attempt it or.
Okay, and it is time limited 90 seconds only. Okay. So team A, ready? So your first question, which scoring system is used for ICU airway assessment?
Pass. You can pass on. Or next.
Bicarbonate ion in ABG is measured or calculated parameter?
Calculated parameter.
Correct. How driving pressure is calculated?
Inspiratory pressure minus the PEEP.
Correct.
P plateau minus PEEP.
Correct. Drug that can be used for rapid reversal of rocarinum and in cannot intubate, cannot ventilate scenario.
Sugamadex.
Correct. The Lindegard ratio is used in transcranial Doppler to identify.
Pass.
What type of ECMO is used in severe ARDS patients?
VV ECMO.
Correct. Hallmark sign of refeeding syndrome?
Pass.
Hyperinsulinemic euglycemia is very effective in the treatment of which toxicity?
Pass.
What is the principle of below machine?
Pass.
A person well known as a father of ECMO who recently passed away.
Pass.
So which scoring system is used for ICU airway assessment? Time is over.
You can always pass the question rather than the person who is holding the mic will only get the chance to answer. If the other person prompt for outside, we will not take that answer. Okay? The person who is answering should hold the mic.
So I will just tell the answers. Which scoring system is Makocha score? Bicarbonate is a calculated ion. Driving pressure is plateau pressure minus PEEP. Drug that can be used for rapid reversal is Sugamadex. Lindegard ratio is for vasospasm in SAH. ECMO you have correctly answered as VV ECMO. Hallmark sign of refeeding syndrome is hypophosphatemia. Hyperinsulinemic euglycemia is very effective in treatment of calcium channel blocker toxicity. And the principal, the machine we have shown is the iron lung, which is a negative pressure ventilation. And person well known for father of ECMO is Dr. Robert Bartlett.
So 30 marks for team A. Okay.
So team B. Team B ready? First question, mottling score.
Start the timer.
Mottling score for shock assessment is done on which part of the body?
Knee.
Correct. Which ratio is used in Kigali modification of ARDS?
Pass.
PEEP is beneficial in right heart failure, true or false?
Attempt it. Pass.
What modality other than tidal volume have shown to decrease mortality in ARDS patients?
PEEP.
Wrong.
Wrong. Next question.
Tigecycline doesn't have pseudomonal coverage, true or false?
Wrong. True.
Blood group cross matching is mandatory for cryoprecipitate before transfusion. Value of pulse pressure variation for predicting fluid responsiveness is okay, more than 12. Aluminium phosphate poisoning has very high mortality. What treatment modality have shown very high survival? Cell phos poisoning.
यही तो प्रश्न.
5 seconds.
What does this ventilator waveform suggest?
Time over. So tigecycline doesn't have pseudomonal cover. What did you answer?
False.
That's true. That's true. It's a true. It's not false. Okay. So you have total 30 marks. Please speak loudly on the mic so that we can hear.
So can you attempt this question? Anybody wants to attempt?
Obstructive disease.
No. Auto PIP. One more question. Yet to start for the team C. Just the leftover questions I can discuss.
Finish it.
Complete.
We'll let it.
Okay. Team C. So ready? Timer.
Please speak loudly and start the timer.
ROC scoring system is used for assessment of which device functionality?
Next question.
What is the target driving pressure?
Less than 15.
Correct. Intermediate syndrome is seen in which
OP poisoning.
Correct. Which neuroanatomy of focus is used for ICP interpretation in ICU?
Next question.
What is the recommended fluid of choice for resuscitation in sepsis?
Normal saline.
Wrong. Pulse pressure variation monitoring can be done in spontaneously breathing patient. True or false?
False.
Correct. Iron supplementation should be avoided in patients with active infections. Yes, sir.
Yes.
Correct.
Salicylate poisoning is treated with what modality other than dialysis?
Next question.
This iconic image is a milestone in the development of
Next question.
what is measured with this technique?
Ten-second left.
Intra-abdominal pressure.
Correct.
Right.
You want to revisit any questions?
Which ROC scoring system is used for assessment of which device functionality?
HFNC.
HFNC. Right answer. So 10, 20, 30, 40, 50, 60.
So this is the image for ECMO, Dr. Bartlett and Esperza for survival of ECMO patient. And salicylate poisoning, the answer is urinary alkalization. You have already answered it right. Iron supplements.
Team D.
So team D, ready? Timer reset. First question. Hacker score is for the importance of success or failure from winning of. Correct.
Right answer.
What is the cerebral perfusion pressure?
Cranial pressure.
Correct. Right. Acute COPD exacerbation, ventilator settings, respiratory rate should be low for CO2 washout. True or false?
True.
Correct. What is the sweep gas used for ECMO? Correct. What is the normal osmolar gap?
Less than 10.
Most accurate method for determining resting energy expenditure is? What ultrasound is being performed here? Steroids are safe in a patients with severe traumatic brain injury. True or false?
Right.
Drug of choice or newer drug available for dabigatran induced bleeding is?
Yes.
Correct. What is the mode of ventilation in following ventilator screen?
Yes, yes,
Correct,
yes.
correct.
The question remaining is image लगा देना वो. Most accurate method for determining resting energy expenditure is. Then image. Please show the image. Yes.
M-node.
No, it is Vexus. 1, 2, 3, 4, 5, 6, 7, 8. 80 marks.
So, indirect calorimetry was the answer for resting energy expenditure. So, team E.
Get ready.
Ready? First question. Characteristic differential feature between calcium channel blocker and beta blocker toxicity is?
Pass.
Rapid shallow breathing index for successful extubation is?
105.
Yes.
Less than 1. Fecal microbiota transplantation is primarily used for treatment of?
In children's Clostridium difficile.
Please louder.
In children's it is used for Clostridium difficile.
Yeah, right answer. Next.
Adenosine is contraindicated in patients with bronchial asthma.
Yes or no?
Yes.
Yes, right answer. Next.
Which renal replacement modality is used in patients with severe shock with high dose vasopressors?
Pass.
What will you do with the following ECG changes?
Next.
The Curve 65 scoring system can be used for
ICU admission.
No. Next.
console screen suggest on which support the patient is on.
IABP.
Yes.
What is the diagnosis?
Pneumothorax. Pneumothorax.
Yes.
The first drug to be given in case of refitting syndrome is
Revise.
Revise. Characteristic differential feature between calcium channel blocker and beta blocker toxicity is.
Pass. Pass. Pass.
Which renal replacement modality is used in patient with severe shock with high dose vasopressor? Yeah, right answer. Done. So 10, 20, 30, 40, 50, 60 marks. Good going.
So team F, the last team. Ready? Timer. Answers. Characteristic differential feature between calcium channel blocker and beta blocker is
validate function
hypoglycemia.
also here.
Rapid shallow breathing index for successful extubation is less than 105. Fecal microbiota is to treat C. diff infection. Adenosine is contraindicated in bronchial asthma. Renal replacement modality in severe shock with high dose vasopressors is CRRT. The ECG changes in which is seen here is do nothing. It's just an artifact. Then the Curve 65 is used for community acquired pneumonia for severity and place to admit. The screen was of IABP. The diagnosis of USG was pneumothorax, and first drug to be given in case of refitting syndrome is thiamine. ICU admission. So next team, team F. Okay. Timer ready. First question, Hunt and Hayes scale is used for. Correct. For diagnosis of brain death, which bedside test is performed? Low SpO2 but normal SaO2 and PO2, which commonly known as saturation gap is seen in which condition? Correct. At what abdominal pressure you call it as intra-abdominal hypertension? Correct. Above product is named after a scientist. What major contribution he has done in the field of medicine? What? Antiseptic surgeries. What is the next best step for following condition? DVT prophylaxis is a part of WAP bundle, yes or no? What is the use of RAS scoring system in ICU?
Yes.
In which disease condition APRV mode have shown benefits? Which drug is used for prevention of vasospasm in SAH patient? Correct.
Yes.
Revise.
And
Question 2. Correct. Next best step.
Time over.
Time over.
70 marks.
Team F gets 70 marks.
So the round is over. We will go for the scores.
So please give us some time. We'll calculate the score and we'll display on the screen. So meanwhile, we have Dr. Afzal Sheikh. He's the
Hunt and Hayes for SAH prognosis. For diagnosis of brain death, already they answered as an apnea test. Low SpO2, that saturation gap is with hemoglobinemia, even in carbon monoxide poisoning. At what abdominal pressure is more than 12, you called as intra-abdominal hypertension. The product Listerine is named after father of antiseptic surgery, that is Joseph Lister. The next best management is to withdraw tip by few centimeter. It was right endobronchial intubation. Then DVT prophylaxis is a part of VAP bundle. RASCO is for sedation analgesia. APRV mode is beneficial in ARDS patient. And drug use for prevention of vasospasm in SAH is nimodipine.
हाँ वही हम मेरा वाला निकल है क्या वो चालू फर्स्ट सेकंड थर्ड ये एक्स्ट्रा मशीन घूमना चल
Rapid fire 2 निकाल.
इसमें से निकल
Few questions for audience. Rapid fire.
दूसरी पीपीटी फट से बना के डाल दो ना सर। हाँ तो अनाउंस कर देते हैं। तो ये समझ गया ना सर, ऐसा इनफ है, कुछ मत करो।
Rapid fire 2.
सर
Rapid fire 2.
सर
ठीक है क्या है अगर ये खींचा क्या है
Scores are ready.
She will announce.
So,
I thank judges for just covering us meanwhile. Thank you, ma'am, Manohar ma'am. Thank you, Deshpande sir. Thank you, Upadhyay sir. Please have a round of applause for our judges. So,
अभी के अभी हाँ हैंड ओवर कर देते हैं।
थर्ड से बोलना चाहिए पड़ेगा। Yes, so we have already scored displayed. So the third prize for the quiz competition goes to Team E, IGGMC Anesthesia. It includes Dr. Santosha Lakshmi, Dr. Intiqab Ahmed Khan, and Dr. Pranali Dhakne. Well done, Team E.
I request Deepak sir to please hand over the check to them.
Oh, check off how much?
Good amount, very good amount.
Arey
We are not declaring any amount. We are.
बोलो ना।
सर जैसे नहीं करते हैं हाँ ठीक है
No, we are not declaring an amount. Yeah. So I request
IGGMC
all three to please come
Anesthesia.
forward. Please come forward.
Get disappointed. You are a winner.
सर्टिफिकेशन हाँ है ना सर्टिफिकेट फर्स्ट अब नाम लिख लेंगे ना वो दे दो फर्स्ट रनर
Sir, please hand over. I request Nikhil sir to hand over the certificate to them. Sir, please come forward. And Chafle sir will come forward, please, sir, for to have a photo together.
तीनों साथ में
Ganjre sir, please come. Ashish Ganjre sir.
The second prize goes to.
Any guesses?
The score is
Any guesses for second round? Already है यार ये दिखा है वहाँ पे.
Team D Medicine, GMC Medicine Department. Dr. Rajesh Ban, Dr. Tapas Jain, and Dr. Ayush Shikichi.
Congratulations.
They have just from last 10 marks. A big round of applause for them. And the first prize goes to Team F, Medicine Department, IGMC Nagpur.
I request Barokar sir and Nirmal Jaiswal sir to please join to felicitate our winners. Also Tanuja Manohar ma'am and Deshpande sir to join please. They were our emergency judges. Please sir. Please ma'am.
Dr. Prabodh Sardar, Dr. Chaitanya Ghule and Dr. Anushka Joshi. Big round of applause for them.
We are very proud of you all because we are IGMC.
नहीं दे देते फोर्थ फिफ्थ सीट भी बुला लो बुला रहे हैं
We request all other to please join us on the stage. All other teams.
So we'll felicitate first team fourth one.
Fourth हो गया. अच्छा. Team A and B, both of them are at 90 points. Please come on the stage. Team A and B.
So I request Jeswani sir and Chafle sir to felicitate team A and B. Please come forward, team AB.
Team A, we have it from NKP Salve, Dr. Shadab Badar, Dr. Mahek Rati and Dr. Prajakta Mahare.
I request Barokar sir, Jaiswal sir and team B.
Team B, Dr. Vaidehi Somani, Dr. Tanvi Khatid and Dr. Prayank Panikar. Unfortunately, who was the winner of our preliminary round? Team NKP Salve, yes, you were the winner of our preliminary round. Please come on the stage, please.
I think winning and losing is just part of game. You were good, you performed well. So cheer up. Please, please. Utkarsh sir. Bhutra sir, please come. Ready है ना? So हाँ sir, please come forward. Certificate दे दो, certificate class 3. Radhe.
Master की photo. Quiz masters. All quiz masters. We will take the photo. Valedictory function is about to begin. The conference is over. We will take the quiz masters photo and start with the valedictory proceedings.
So we'll be having a valedictory function here. Please keep waiting. So please, quiz team, please come on the dais. Afzal, Paras, Rashmi, Harish sir, Shailesh.
Very well. Thank you, sir. Thank you, sir. Hello. सर के सारे आंसर में सुन रहा था सर।
नहीं नहीं, आपको एडल्ट वाली कॉन्फ्रेंस थी ना, इसलिए चाइल्ड का कोई नहीं था अपने यहाँ पे। हाँ। अभी हमारा वैलिडेटरी फंक्शन चालू था, वो हॉल में, बाजू के हॉल में आए हैं। हॉल में आप आ सकते हो, वैलिडेटरी फंक्शन चालू था। हाँ।
पीयूष संकेत प्लीज कम ऑन द डायल. All participants, please wait for some time. We'll be having a group photo together. All quiz participants, please wait. All quiz participants, please come on the dais. Team A, Team B, Team C, Team D, E, F. Please wait. We're calling you. Please wait for 2 minutes.
I really don't know. मुझे तो अभी पता लगा।
Congrats, very good.
Shit.
पहला वाला ना ये एक ऐसा
Player of the series. Participants, please join us. Please, everyone, please. Come on. आ जाओ.
All participants, please.
Please आ जाओ. आइए ना आइए. आ जाओ. आ जाएंगे. 20-25 किलो की वैसे ही. 17 की
तो सर पहली बात तो आपकी बात है पहले मत लो
सबको एक हाँ जय 15 की दारू
Thank you everyone for joining for the quiz. Thank you.
चलो चालू करो पहले
Everyone, please be seated here. With the end of quiz, we are concluding the conference. So please wait for the validatory function. Everyone, please be seated.
की बोलना वैलिडिटी फंक्शन है आपने तो बोल नहीं बात कर अपनी को अटेंडेड रही लेक्चर रखेंगे अभी देखिए दोबारा सिखा के कॉल में इंट्रो सरकार से जहां को लेके दो काम खाली है जो पहली स्लाइड है मैं एक ही स्लाइड और फॉरवर्ड करके तो आज के लिए तो तुम्हें पारस जेव्हा कोणाला काम केलं एक स्लाइड वरती जो फोटो काढून घ्या आणि पुढच्या व्हिडिओमध्ये आपण गाण्यांसोबत आता येथे एक पेपर होता मी यांना सांगितलं होतं यार भाई ठीक है फोटो काढूंगे ना फोटो काढायचा थोड़ा फास्ट सब शादीशुदा
तो स्टार्स में डालो ना आपके सारे
डाल देंगे
I hope everyone has received the certificate. If someone is missing, please let me know.
उधर चालू है उधर चालू कर उधर चालू कर दीजिए हम आते हैं हम लोग ज्वाइन करते हैं गजानन वहाँ चालू रहने बोला आ रहे 5 मिनट
चलो बैठो पर सब जन आपके लिए यार तुम बोलो बैठने के लिए मैं वैलिडेटरी कैसे मैंने पूछा था वैलिड
All of you are requested to please take your seats quickly. All seniors, friends, please take your seats. We will take your 10 minutes only for valedictory. Please take your seats. Sudhir will propose the vote of thanks. He'll just take your 10 minutes, please. Please be seated.
पारस बसा संकेत बसा बसून जा पहिले संकेत ए संकेत बसून जा ना Good afternoon, everyone. Our distinguished guests, my colleagues and friends. Let me start with giving thanks to God Almighty for making this Mahakritikan a grand success. आवाज बसलेला आहे. As we come to close of this remarkable conference, it is both honor and privilege to deliver the valedictory address. The over last 3 days, we have witnessed an extraordinary exchange of knowledge, experience, and innovation. The critical care, without doubt, one of the most demanding and dynamic field in the modern medicine. It calls for precision, teamwork, resilience, and above all, compassion. Through the lectures, workshop, and discussion held during this conference, we are reaffirmed that the critical care is just not about the advanced technology or complex protocols. It is about the human spirit and about bringing hope where the odds are very slim and about standing by our patients and their families in their most vulnerable moments. On the behalf of organizing committee, I would like to express our deepest gratitude to our chief guests, esteemed speakers, panelists who share their wisdom and expertise with such clarity and generosity. Your contribution has enriched all of us. A heartfelt thanks to all our delegates and participants whose enthusiasm and engagement made each session dynamic and meaningful. We must acknowledge the organizing and scientific committee, the sponsors, the support staff, and people working tirelessly behind the scene to make this conference a success. And now it's our honor itself to honor of our star team. And so I request Dr. Deepak Jeswani, our patron, Dr. Nikhil Balanke sir, Dr. Nirmal Jaiswal sir, Dr. Rajan Barokar sir, and Dr. Ashish to come on the stage to felicitate our own people. So I start with alphabetically. Yes, it will be on alphabetical. आता बसान थोडा वेळ आता आले मगाशी चालू होते ह्या दोन पुढे नीरज एबीसीडी लावले ना सगळे हो हो ठीक आहे द्या माझ्याकडे द्या मी सांगतो पहिले ते माझ्याकडे द्या मीच वाचत जातो. First of all, I request Deepak sir and Ashish to felicitate our patron, Dr. Nikhil Balanke sir. Dr. Nirmal Jaiswal sir. Dr. Rajan Barokar sir. Girish Guruji, Dr. Girish Deshpande. नाही नाही, तुम्हाला थांबायचं आहे. तुम्हाला तिथं थांबायचं आहे. हो.
आम्हाला ते
फोटो बघून नाव हे टेस्ट करून मला असं सांगा तर. चला फोटो घेऊन ना. डॉक्टर कमल बुचाडा सर, पहिले पास प्रेसिडेंट होऊन जाऊ द्या ना. आता कोणतं आता फोटो बघून हो. कमल का कहा गया जो दिख रहा है प्रेसिडेंट का तो होना वैसा करना. हाँ वही मैं बोल रहा हूँ. कमल का देख, कमल कमल दूसरा फिर आशीष का दे. बस आता माझे प्रेसिडेंट राहून जाईल ना. जाऊ द्या माझं हो. दोनों मेरे बाद में थोड़ा आना पड़ेगा मुझे फिर पास. हाँ डॉक्टर पल्लवी मेश्राम.
कमल का है. अरे दे ना.
सबसे मैं वही बोल रहा हूँ. डॉक्टर रितेश दीक्षित. डॉक्टर तुषार पांडे. डॉक्टर अजय साखरे. डॉक्टर अमोल मेश्राम. नहीं आला ना तू. डॉक्टर बिपिन जिपकाटे. डॉक्टर नितीन शिंदे. नहीं ये नावच नाही. डॉक्टर संजीव बैस.
संजू है. संजू. संजू जय श्री राम.
डॉक्टर आनंद जोशी. नहीं हाँ एनके जोशी एक हुआ.
वो बैठे हैं सर.
डॉक्टर एनके जोशी. डॉक्टर अनुपमा झाडे. डॉक्टर अजय बुल्ले. डॉक्टर चेतन शर्मा. आम्हाला सांगितलं. डॉक्टर दीपक पाराशर. डॉक्टर अंकिता राजपूत. डॉक्टर अनंत सिंह राजपूत. डॉक्टर परीक्षित महाजन. ते नाही म्हणते. डॉक्टर दिलीप क्षीरसागर. डॉक्टर राकेश ढोके. शांत. I will find out. Dr. S.K. Deshpande, sir. Dr. Piyush Dawad. A man behind Intensiv's Got Talent. Dr. Amit Baheti. Dr. Sohail Parate.
नहीं रश्मि अग्रवाल
One of our MSc, Dr. Rashmi Agrawal. Dr. Shailesh Lute. Dr. Neha Agrawal. And Dr. Shivam Puniani. Dr. Shailesh Chokse. Dr. Vikas Gupta. Dr. Kaustubh Upadhyay. Our treasurer. पैसे उसी लेना है पैसे उसी देना है डॉक्टर हरीश चौधरी डॉक्टर नरेंद्र बंदे डॉक्टर प्रसाद देशमुख डॉक्टर अफजल है ना
और किसकी ये बच्चा ना से मिलने इसका है
पारस का नहीं है स्वप्ना का नहीं है डॉक्टर स्वप्ना कांजोड़े डॉक्टर पारस झुनके और कौन देखे
आप सामने आ
Dr. Piyush Kotewar. Dr. Ramesh Hassani. Dr. Sanket Agrawal. Dr. Rahul Hiwan. वो तो नहीं है. हाँ हाँ. 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 Dr. Milind Vangari. Dr. Sushant Sardek. Dr. Bhushan Itkelwar. Dr. Abhishek Kesarwani. Dr. Rupesh Bokde. Dr. Mahesh Sada. सरांचं बाकी आहे नंतर पाहू ना आता आमचं होईल तर होतं जाऊ दे.
नहीं एक भी भूल ना
और क्या बोला तूने? और क्या बोला? डॉक्टर नीरज बेले. कोण राहिला का तू? झालं. हा, चल. Now the Secretary of SCCM Nagpur, who worked tirelessly for this organizing event, I request Utkarsh to come forward and have a big. Now, हो गया I may miss a name of some person inadvertently, so I request you to come forward if you miss name of the one of the stars. अमोल पराते, सागर चोपडे.
सुधीर आमचा धीर संपला आहे. Two people are still missed out, or more than two. One is Sudhir Chafre, Deepak Jeswani, and Ashish Gandre. Please come over. Utkarsh, Lala. So, Utkarsh, please come over. Felicitation. आता have a very, very big hand for these three trio who have done wonderful job. They have been busy for 1 year. Just imagine, they have been working hard for 1 year, and that's why this day has come where we are happy celebrating. Wonderful job, Deepak, Ashish, Sudhir, Utkarsh, all of you. Amazing work.
Actually, I am accidental secretary. All thanks to Kamal. He is supposed to be a secretary of this Mark in the contract. And because of our pattern, Dr. Nikhil sir, Dr. Rajan sir, and Dr. Nirmal. Chala. Please. थोड़ा धीर धर मुझे माझं काय राहिलं नाही झालं व्हायचं. We are also grateful to all our event partner Himanshu and his team. They work tirelessly. Himanshu, please come forward. Himanshu, with your team. Yes, audio visual. Gajanan from Yes Audio Visual. Mithun. Mithun. थांबा ना चालू. अरे सर थांबा. My special thanks to all farmers, especially Intas and Brigade. Now I request Deepak sir to felicitate Mr. Shailesh Markondwar. He worked very hard with us to facilitate most of our travel and arrangement.
Shailesh has done a remarkable job. He is not from pharma. He is our friend.
Thank you, Shailesh. I hand over to Deepak sir for 1 minute.
Just 1 minute. I will take your 1 minute only. I came close to this team of Star Mahakriticon since last 6 to 8 months. And actually, I don't have words to express. I'm speaking from my heart. I'm overwhelmed. I don't have words. But this is the excellent team. And all the speakers were very happy with the cohesiveness what we have. My humble request to you all that please keep this cohesiveness with you, because you all know that lot of groups are there in many cities. I don't want, and none of us want any groupism or anything to enter. Remain like this, जैसे हो वैसे रहो, साथ में रहो. साथ में रहोगे तो अच्छा रहेगा, बटोगे तो कटोगे, जो आपको मालूम है. तो आप सब लोग अभी सब लोग स्टेज पे आइए. आपको सबको एक ट्रॉफी दे रहे हैं हम लोग, वो सबको उठाना है वर्ल्ड कप. सब लोग आ जाइए, पूरे स्टार्स. प्लीज प्लीज कम ऑन स्टेज. जितने आते पूरे आ जाओ, पूरे सब लोग आइए प्लीज.
Now I hand over mic to Dr. Nikhil Balanke sir. Finally.
Yes, Deepak, Ashish, and Nirmal Rajan, please stay back. Also, Sudhir, come here. Utkarsh, Aja tu. This is just another maybe 5 minutes before we go for our lunch. I request the all agile hospitality staff, please share the champagne glasses with all in the crowd, and we would like to raise the toast for all our stars. फक्त अबे पिऊ नका रे 2 मिनिटं. फक्त हातात धरून ठेवा. आणि मी जेव्हा म्हणेल रेस द टोस्ट, तेव्हा रेस करा आणि घोटभर प्या. So this is the toast we are raising for the camaraderie of the critical care team in Nagpur, the SCCM team in Nagpur. So this is for long live SCCM Nagpur, long live team Mahakriticon. घ्यायचं आहे माझ्या हातात घेतलं म्हणत मी घेतलं. So today we can proudly say that we have hosted the most successful and the best ever Mahakriticon in 13 years. Hip hip, hip hip, hip hip. Great. Yes, I do want the but clean me so. So Deepak and Ashish, This was a wonderful experience. Mahacriticon 25 with all your efforts and everyone else was a wonderful experience, a great academic feast. I should say, नाही नाही, अभिषेकामुळे रेस जो टोचते मा सुधीर अधीर थांबा थोडा धीर धरा. A wonderful experience. यहाँ से नीचे नीचे उतर और लेफ्ट में 200 मीटर पे फाइब्रोस्कैन फुकट में हो रहा है. So I should say Mahacriticon 25 was a perfect blend of academic feast, knowledge sharing, and of course professional camaraderie also. In spite of all, we were so much busy. We know we were all busy. We had so many compulsions, but still we could take out time, and on one call, all of us, whenever we were asked for or wherever, and Deepak had, Ashish has taken, every day you were available for everyone. So amazing. So we ask you to raise the toast for the leaders, Deepak, Ashish, Sudhir, Utkarsh. So raise the toast, have a sip, and come back. So this toast is for the organizing committee, and we have another toast for the stars after this. So as we raise the glasses today in the afternoon for this wonderful organizing team, let us take a moment to celebrate this remarkable journey which you made us a part of this journey. So we are very happy to be part of this journey. The Mahacriticon, it was led by vision and passion of Deepak and Ashish. And you really made us dream something which we thought was not possible. And today we find this dream has come true, and true bigger than what we dreamt of. And hats off to whatever you have led, amazing leadership, and you have done a wonderful job. From the first day itself, both of them along with the team worked tirelessly and inspired everyone around them to give nothing less but their best. And we did that. We are proud that we also did that and came to your expectations. Their leadership was not just about direction, it was about inspiration, kindness, and spirit. Not this, the other one. Andar ki spirit. The best part, I'm sure you might have worked with other leaders as well. The best part of this leadership was both of them were most approachable. इतने भी मुझे फोन करो, मैसेज करो, रात को 2 बजे मैसेज किया तो उसका 2:15 बजे रिप्लाई आता है. So they were approachable, empathetic, and लिखते समय मैंने लिखा calm under pressure मालूम नहीं, but calm under pressure भी बोल ही देते हैं. But then of course there are some situations where you cannot keep your calm and you need that adrenaline to drive, because that's somewhere some aggression is required for the result. So it's acceptable, not a problem. And they were always ready to help anyone every time. Every challenge was met with courage, every detail were handled with care, and every heartbeat with same purpose to make this conference most unforgettable. And you could do that. What we witnessed was not just a conference, it was a celebration of teamwork. And this celebration will continue for 1 more year till we meet again in Aurangabad. And it was teamwork of trust and excellence. A beautiful example of what can happen when great minds and good heart come together for a shared dream. So you created a dream and we shared it, and we call ourselves great brains also. So yes, raise the toast for Deepak and Ashish and his entire team for dedication, unity and spirit. Yes to a Mahacriticon, a shining chapter in the history of SCCM Nagpur. Hip hip, hip hip, hip hip. आता सगळ्यांनी आचमन करावे. एक घोट. मला खूप भेव वाटते. Now this toast is for all the stars who came here to take that small gift what we could give but that's going to be cherished for life. I'm sure it's going to be there on everyone's table, reminding you of what you have been doing for 1 year, and will remind you and inspire you to do something much more better, bigger in days to come. And we're looking forward for that. Let us now raise the glasses for our stars. हे आता घोटीने घ्यायचं बरं, फक्त रेजन ठेवा. हा. Let's celebrate not just all the stars. Let's celebrate not just the success of Mahakritikon 20. Spirit that made it truly special. The spirit of stars of Mahakritikon. Hip hip! Hip hip! Hip hip! From the long demanding day of workshop, अबे स्टार पड़ता है, तारे जमीन पर आ रहे हैं. हो गया. पोचले भावना. So for all the stars, from the long demanding day of the workshop to the busy hours of this entire conference for 2 days, you all stood tall, calm and committed and full of heart. That's we all, it's an enviable thing for all of you to do. You made every challenge look effortless and every moment shine brighter. Your teamwork, empathy and quiet strength of it was a quiet strength. We could get only after we saw the results. We said, "अरे ये तो सब आराम से हो ही गया है." So that's unspoken. That it's a quiet strength which turned this demanding journey into a joyful memory. You are our constant support, our strength and our pride. And we were always sure when like Deepak, Ashish say, "अरे ये अपना हो जाएगा." मैं बोला Deepak, अरे तुम उसका लोड मतलब हम करवा देंगे. And they all stood to all your beliefs. And so here's to all the stars of Mahakritikon for your brilliance, for your warmth, for your unwavering spirit, a shining symbol of passion, purpose and togetherness. Raise the toast and have a sip. Stars of Mahakritikon. नाही, अजून 2 आहेत. Now to this wonderful, और कोई है क्या? हाँ इधर भी है. To this wonderful staff of Center Point Hotel. अभी कुछ लोग तो बिजी है, वो जो भी है हमारे भावना उनको आप communicate कर दीजिएगा. All the chefs behind you, this hospitality staff, you all people, it was a wonderful experience for us. Monish, Amit, Veer, and of course Vicky. So all from the top. अभी वो I think he is still outside India तो आ नहीं पाए. आगे? हाँ Thailand. मेरी कल परसों ही बात हुई उससे. So let us take this moment to appreciate the wonderful team of Hotel Centerpoint, the people who made Mahakritikon not only successful but comfortable to all of us, comfortable to our faculty who were very happy and they went home with very good memories from this place. आपकी गर्मजोशी, तत्परता और हर छोटे छोटे विवरण पर ध्यान से हर अतिथि को आपने विशेष महसूस कराया. They really felt very special when they are going. Lot of people, there were about 5 or 6 who said, मैं तो 6वीं बार आ रहा हूँ, फिर भी अच्छा ही लगता है यहाँ. So that was what we got. So हर आयोजन पर आपके लिए अब सब बधाइयाँ हैं. सुबह से लेकर रात तक आपकी मुस्कान कभी नहीं थमी और आपकी मेहमान नवाजी में कभी कुछ कमी भी नहीं हुई. So here's for the Center Point team for your grace, professionalism and care. Raise the toast and have a sip. बरं आता जेवढा उरलेला आहे ना आता संपायचा आहे बरं. हे शेवटचे 1.5 मिनिटं अजून आहे. For all our pharma colleagues who are here, raise the toast for all these beautiful people who have all the time been generously behind us to help us. We planned something big and you make it big. So raise the toast. So
and we raise the glasses, let us take the moment to express our gratitude to all of you, to our pharma partners. Your silent strength is always behind the success of Mahacriticon. You never, like, you've been there, we are enjoying the sessions, and it's only because of your unconditional support we could do all these wonderful things here. Your educational support, your grants, your faith in our vision, and your commitment to advancing the cause of critical care medicine have truly made this conference exceptionally good. So here's to our pharma collaborators and friends for your trust and for your generosity and for your enduring partnership. Raise the toast and finish the toast. Mahacriticon 25. Hip hip, hip hip, hip hip. And Shailesh, फ्रेंड्स के लिए कुछ अलग पेज नहीं है, बट यू हैव अ स्पेशल टोस्ट फॉर शैलेश फॉर सम वंडरफुल थिंग्स यू डू. तू तो 24 में से 25 घंटे अवेलेबल रहता है. तो हिप हिप हुर्रे, रेज द टोस्ट फॉर शैलेश. हिप हिप, हिप हिप. And let us have our lunch and we meet again. Sorry.
एक बार आखिरी बार और रेज द टोस्ट फॉर नन अदर देन अमिताभ बच्चन, डॉक्टर निखिल बालंके. हुर्रे, हिप हिप, हुर्रे, हिप हिप, हुर्रे. Thank you all, and accept a small token of gift from SCCM Nagpur to all the stars. Dheeraj will hand it over to you, and we have still forgotten very important member of SCCM family. Dheeraj, please come forward, please. And now raise the toast for Dheeraj. ये पिएगा. Thank you. I'll invite all the stars to on 4th floor Bougainvillea for lunch. Please come. जो है फटाफट दे दे, हाथ दे दे. धीरज आ जाना. I will request Mrs. Lohia to come on the stage. She is a decorator for all our events on 7th, 8th, and last night during our banquet. A big round of applause for her. Fourth floor Bougainvillea for lunch. Please, quickly.